The meeting is live on YouTube now. Team, just wait for 2 minutes and wait for my cues.
Good evening, everyone. A warm welcome to all of you. First of all, thank you so much, Sunila ji, इतने अच्छे गार्डन वीडियो के लिए जो अभी हम सभी ने देखा. By the way, मेरा नाम डॉक्टर पूजा है और मैं आप सभी लोगों का इस जूम कॉल पे जो कि देश और विदेश से जुड़े हुए हैं या फिर जो लोग फेसबुक या यूट्यूब से लाइव स्ट्रीमिंग देख रहे हैं, इन सभी का मैं शॉग्रेन इंडिया की तरफ से हार्दिक स्वागत करती हूँ. First of all, let me inform you that this session will be in English. However, for Hindi-speaking audience, the important points will
There seems to be some technical glitch. Pooja, are you having internet problems?
Yeah, I think Pooja is.
Yeah, I think Pooja
frozen.
is getting stuck. So maybe I will take over. Hello everyone, Namaskar, Adab, Sat Sri Akal. I'm very happy to see all of you from various parts of India and also from other countries. And it's wonderful to have so many patients and a wonderful panel of doctors here with us. We will start the program. Pooja's had a little bit of a technical glitch, but that's all right. That is expected in an online program. This is a very special event, which we have chosen to call Sjogren's Dialogues. This is a dialogue between doctors and patients. 15 years ago, on a similar day in July, we started Sjogren's India. We had our first patient education program that day at a small hall in Sterling Hospital. Fortunately, Dr. Sapan Pandya, who was there then, is here today now also. And he has been supporting this cause for all these years in between. Today, things are quite different. We've moved a long way from those days when it was difficult to convince patients to talk about their illness. It was difficult for us to convince them to join a support group and seek help and learn to manage their own illness. There was this belief that doctors are going to solve all their problems. And it has taken us a good 15 years to bring this awareness about a disease which is more often than not misunderstood, underdiagnosed, and very often I feel even neglected by the medical community, neglected by the families, neglected by society. And therefore, it has been our endeavor for the last 15 years to continue raising awareness about Sjogren's, raising issues about what patients go through on a day-to-day basis. And today we will also hear a patient's perspective that we have put together after doing a little study. And we are very grateful to a lot of patients who have given their inputs into this study. And we are very happy to be presenting it today later on. One of the reasons why July is such an important month for Sjogren's is that may I please request everyone to please keep their mics on mute? May I please request everybody to keep their mics on mute? we missed doing the house rules session, but that is all right. We will take that in but please keep your microphones on mute if you are not speaking. Towards the end of the program, we will probably have some time when people can speak, but let us see how the program unfolds. So as I was saying, 23rd July happens to be the birth anniversary of the doctor who first put together all these varying symptoms and described Sjogren syndrome. So that day, 23rd August, which is the birth anniversary of Dr. Sjogren's, has been not celebrated, but we use that to commemorate his memory. And it is the day that we try and raise awareness about this condition all over the world. The International Sjogren's Network decided upon this date at a program in Brest in 2009. And since then, we have been trying to do some special event in July. This time, it's really special because we are trying to do a program where patients and doctors are together on the same platform. And we are hoping that this is a beginning for patients and doctors to work together for conquering this lesser known condition. Before we go into the event, we will of course be having not only presentations by a very, very eminent panel here. We will soon be hearing their introductions. One of my colleagues will be introducing all the eminent panelists here. We will also have a question and answer session towards the end of the event. We will take a short break around 6 o'clock because we realize that patients need a short break. So we will have a 5-minute break, and we request you all to please come back immediately because we do not want to delay the program. Before we get into the session, a quick round of audience poll. This would give us an idea about who are attending the program. I would request everyone to please participate in the poll. It's a very simple poll which you will see on your devices. All you have to do is to click the right answer. I'm sorry that the people on Facebook and YouTube may not be registering on the poll, but you can please put your answers on the comment section. So if you could please just fill in the forms, we'll start now. Please don't forget to click the submit button.
You have 30 seconds to request if you can just quickly put in your responses, please.
We are from out of India, but there is no option of...
There is an option of outside India. There is an option. If you just scroll down, there's an option for outside.
Thank you.
There is the box of there.
Another 20 seconds and request you all to quickly. Okay, so I'm just going to end the poll now and share the results. We have a very, very large number of patients. It's about 41%. Those with family are about 22%. Only family members is 16%, and the rest is 22%. Regarding the regions from where we've all logged in different parts, the highest, of course, is Western India, 41%. We have many from outside India as well, which is 19%. and the remaining from north, south, east, and central India. So thank you. Thank you so much.
Thank you, Radhika. That gives us a nice overview of where people are listening to us from. So the doctor's question, where is the audience? This is the kind of audience we have. And one of the things that Sjogren's India has always insisted is that families are a part of every event, because we believe that Sjogren's affects families. It doesn't affect only the individual, it is the entire family which is affected. And therefore, we always have family members with us. So with this, let us move on to the main event. I'm trying to give the doctors as much time as we can allow. So without much ado, let me request may I request Mr. Roy to take over? May I request Mr. Roy to take over the introductions?
Yeah, good evening, everyone. Today we have with us eminent doctors to guide us and educate us in this forum. It's a great moment for us to have Dr. Debashish Danda as a moderator for the panel discussion. I present here a few of his achievements. Dr. Debashish Danda has done his postdoctoral studies in immunology and rheumatology, and had also done his advanced training in rheumatology in the University of Adelaide, Australia. He is the founder and professor of Department of Immunology and Rheumatology at CMC Vellore. He has the honor of being the president of Asia Pacific League of Associations for Rheumatology and is the immediate past president of Indian Rheumatology Association. Dr. Debashish Danda has 252 publications to his credit and has been the editor-in-chief of International Journal of Rheumatic Diseases. One among Dr. Danda's many great contributions to Sjogren patients in India is the seminal research in India. And Dr. Sandhya was a member of this research team. Together, both doctors, Dr. Danda and Dr. Sandhya, researched and published using data collected during the period 2005 to 2012, pertaining to 332 patients, which is the largest single center series in the world. This is the only center included in the Sjogren Big Data project by the World Sjogren Consortium. This center has published almost 12 papers using this data already. I also invite Dr. George Kurian, our guest speaker for the event. He is the ex-professor and an eminent gastroenterologist who served in CMC Vellore from 1979. He has extensive experience in gastrointestinal issues and an expert on irritable bowel syndrome. We have two panel members. I invite Dr. Sapan Pandya, panel member for this program. Dr. Pandya is currently Secretary of the Indian Rheumatology Association, an excellent immunologist and a rheumatologist from Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. He is now the senior consultant at the Vedanta Institute of Medical Sciences, Ahmedabad. Dr. Sapan is a man of multiple talents. He is talented in writing, singing, and is very good orator as well. He was the editor of IRA newsletter. He takes a special interest in supporting support groups. He has supported our Sjogren's India group since 2006. He also supports Antardhwani for ankylosing spondylitis. Dr. Pandya played a pivotal role in commencing a teaching program for rheumatology at Gujarat University. He is also instrumental in bringing together the Gujarat rheumatologists under Rheumatology Association of Gujarat. I heartily welcome Dr. Sandhya Pulukut, panel member. She is a senior consultant and head of the Department of Rheumatology at Stephens College, Stephens Hospital, Delhi. As I had already mentioned, she has been the member of Sjogren Big Data Group and International Sjogren Consortium and has done extensive research along with Dr. Debashish Danda in the field of Sjogren syndrome. And now we come to in-house panel member, Ms. Kirtida Oza. She's a patient leader and co-founder, director of Sjogren's India, a member of International Sjogren's Consortium. Kirtida is a champion who has learned to manage her condition and live better with the Sjogren's over the last 20 years. After struggling through a difficult phase where she had to give up on her career ambitions, she focused her life to take on patient empowerment in her mission. Since 2006, she has been striving to empower patients and families through education, informal counseling, and patient advocacy. She is a member of the International Sjogren's Network, the Indian Alliance of Patient Groups, and the Patients Alliance for Rheumatic Diseases in India. She has been the voice of persons with the Sjogren's and has been articulating the patient's perspective through various national, international forum, print and broadcast media, as also social media platforms. Ms. Radhika Agarwal, she is one among the volunteers who has been actively participating through Sjogren's India. Radhika joined Sjogren's India as a volunteer since May 21. She has extensive experience in the areas of disability sensitization and education, employment, and inclusion for persons with different disabilities in both private and public sectors. She has designed learning and employability training programs, keeping in mind socio-cultural, communication, and behavioral needs. Her interest in invisible disability and the impact such disabilities have on a person's life prompted her to join Sjogren's India and help with the study. Thanks all the doctors and the panel members for having come here and graced this occasion. And I request Dr. Debashish Danda to take over as moderator in this panel discussion. Thank you.
Thank you, Mr. Roy, Mrs. Kirtida Oja. It's a great moment actually today for the patients of Sjogren's as well as for me and my colleagues to be associated with this event. Somehow the pandemic has, in spite of so much of isolation, has actually united us in many ways, because the virtual platform, without traveling, we can connect to a lot of people in different ways. And we have been exploiting this over the last 1.5 years. We have had so many patient meetings, and Sapan and me, as colleagues in the Indian Rheumatology Association, have been involved in various patient education programs. And I'm delighted that Sjogren syndrome, something very dear to this group and colleagues here. I welcome also Dr. George Kurian, an excellent gastroenterologist, a great human being, with great sense of humility, as well as the clinical expertise. Dr. George Kurian was, and me and Dr. George Kurian, very fortunate to be belonging to the same MBBS alma mater of Jipmar Pondicherry, and eventually I again happened to, for the first time met him in Vellore, but He is very popular among the patients. Even today, patients remember him after he retired and joined in Pondicherry PIMS. So I have been asked to in my session that I am moderating. I have been asked to talk briefly about uh, introducing the panelists. Uh, the other panelists are my colleagues. Sapan has already been described. We are together in many activities of Indian Rheumatology Association, and I gave him single most credit for making this forum real and realizing the dream of patients of Sjogren syndrome with this kind of forum is possible because of such a pleasant personality of Sapan. And I think Mrs. Kirtida has rightly mentioned, without his support, it wouldn't have happened. Sapan is very bright clinician, and we're very happy. And Sapan and myself and our common guru, Dr. Ramnath Mishra, had described many years back that Sjogren syndrome doesn't happen so much in India. We published it, the Sjogren's is rare in India. And we were again, later, some years down the line, had to disprove ourselves that we were wrong. Sjogren's is just underdiagnosed. The other person whom I have to say is Dr. Sandhya. Dr. Sandhya doesn't like to be praised in public. So with apology to you, Sandhya, I must tell everybody, she is one of the brightest rheumatologist or even a doctor or physician or a colleague I have ever come across. She's extremely intelligent, thoughtful, and she took her special interest. When I was running the department, I decided that I will distribute the various consultants and ask them what is their areas of interest and give them the responsibility to develop some data on those. So Sandhya was very prompt to volunteer for Sjogren syndrome, and that was very good. And she did so much today that because of her hard work, I'm here today. So I have sometimes, we always express our respect for our seniors, but when your student or junior outshines you, there's nothing more pleasurable than that. So I don't want to say any more about her. I think you will listen to her and you will know what she is. And she is actively interested in Sjogren's research. I want each and everyone in this group who are attending, be in touch with her along with Sapan. And I can tell you that she will be very productive. She's very promising, very productive, very tenacious. And Mrs. Kirtida, I had an opportunity to meet once she came to Vellore, and I had a short interaction after that. I have seen the zeal and the enthusiasm she has, and this is what exactly is needed. When I first time went to Australia out of country, my boss asked me, Devashish, there are two things you must know here. One is the women are equal to men. So you're coming from India, you should learn how to respect women. Second is patient privacy. You must respect the privacy of patient. Without the patient's permission, you should not even tell about the disease to even to the spouses. So that is something very important, and never to their employers unless it is asked by a government or something. So these are the things. And then when I went to first outpatient, and we had the usual Indian habit of telling patients that if they say something, I say that you will be all right. You will be all right. So patients ask back, how do you say I will be all right? So then I realized that the patients are so important that they are part of treatment decisions. Anyway, so I'm going to say in next 5 minutes what I am supposed to say about the history and status of Sjogren syndrome in India. before Dr. Sandhya speaks. It's really very uh, difficult journey, but I would just quickly glance through a little bit of uh, little bit of what shall I say uh, history in a few slides. If I can share my, is it possible I can share my slides?
Yes, doctor, I'm just giving you access.
Okay.
I think you should be able to share your screen.
Okay. Yeah. So can see my screen?
Yes, we can.
Okay, thank you. So I
doctor, would you
is
like
it
to
in the
go in the
slideshow?
slide mode? No, it's
Yeah,
not.
it's not. Okay. Okay.
Yeah, this is great.
Yeah. So the common myths and pearls about primary Sjogren syndrome, as this group everyone knows and Ms. Kirtida was correctly pronouncing, even today 99% of the doctors, including rheumatologists, pronounce it as a Sjogren syndrome. And actually it is Sjogren syndrome. And I learned it why it is so. I had a chance to visit in the Lund University in Sweden, where Sjogren's original thesis was kept. It's in German. And they told that this is how SJ is pronounced like SH. So this is how Sjogren should be pronounced as Sjogren. Second myth is most people expect it to be that the patients will volunteer that I have dry mouth or dry eyes, and also ignore rest of it, and people miss out all the time Sjogren syndrome. Sandhya will tell more about it. And then, as I told you, the Sika symptoms of dryness are not the presenting complaint in majority. Although they have it, they will come out when you ask them with indirect questioning. The third is it's rare in India, and I am also guilty for being part of it, this misconcept in the beginning, along with Sapan and my guru. And we have realized it's no more rare. So what has happened in rheumatology is that we don't wait for the joints to bend, what is called swan neck and boutonniere in, to call it rheumatoid, or we don't want a bamboo spine to call it ankylosing spondylitis. Similarly, we don't wait for very bad dry eye and dry mouth or parotid enlargement by the time the Sjogren's may have a high chance of lymphoma. So is this usual Sjogren syndrome patient will be in the late reproductive age group. They may come to a neurologist or medicine with proximal muscle weakness. They may come to endocrinologists or medicine again with low potassium. They may also be coming to dentist with loss of teeth in a very young age, or they may come to a rheumatologist with joint pain for many years with some deformities and usually get response, or they may come with a nerve related symptoms to neurologist. They may also complain of late fetal death, and Dr. Sandhya will explain it more. Or there may be other gynecological symptoms like dyspareunia. So she may also carry water everywhere, and she has difficulty in eating biscuits or dry food without extra water. And she may be putting eye drops for 10 years, but if you ask a direct question, do you have dry eye, she may deny. So this is the plight of a patient with Sjogren syndrome who goes all over for years together. I'd like to show a picture of these three people and few others I'm going to say later. This is one of my seniors during my training in Sanjay Gandhi PGI Lucknow during my DM. And he is one person, Dr. Sunil Davargaon, who actually was very original thinker and helped me how to think out of the box and why should not go strictly by what is taught and by books and teachers sometimes. This is Dr. Ajay Vanchu. He's now in the US and he taught me how to do a lip biopsy, and you don't need a dentist for the lip biopsy. It's such a simple procedure. And I was in Adelaide for 3 years. And this is Dr. Maureen Rishmuller. I have worked with her for almost 1.5 years out of my 3 years. And she's an expert in Sjogren syndrome, and she's part of the Global Sjogren Alliance. And she made me think how to think of Sjogren syndrome from the back door, from different ways, on indirect clues. And as I told you that I had a chance to see the original thesis of Sjogren's, and it was good to have a feel of that. So in rheumatology clinic, a patient may come with widespread pain, have a non-deforming kind of arthritis, loss of teeth, or they may have indirectly other dryness symptoms in other parts of the body, in the genital area or the skin. Or they may have a nerve-related problem called CIDP, or sometimes serious complications like vasculitis or muscular weakness. This is Vellore, where we see huge number of patients. So we were fortunate, me and Sandhya. Anybody who works sincerely in Vellore will have an opportunity to see almost everything in a short time. So I'm very fortunate. This is Dr. Mishra, my teacher from Lucknow, Sanjay Gandhi PGI. He's retired there as dean and head of the department. And this is another opportunity I had to work with Dr. Hal Schofield in Oklahoma Medical Research Foundation in the Oklahoma City, USA. And he's one of the, again, world experts in Sjogren syndrome. And I had worked with him as a research scholar in his lab. So this was sometimes we described very old data from North India. We said, Sjogren's is very rare. From South India, again, we said Sjogren's is very rare. But is it really rare? So I presented, because I joined Vellore in '96, and I carefully observed and tried to create my own series. First time I presented 126 patients of primary Sjogren's from 1996 till 2005 in Iracon, Hyderabad. And the critics had criticized me, as usual, we Indians are very argumentative in Amartya Sen's words, and many have raised eyebrows. Are these secondary Sjogren's? Are these rheumatoid arthritis? Are Indian RA patients have secondary Sjogren's quite early? Or there are many other experts' comments are there. So it was a journey from disbelief to reality. So what was the background? Well, if you see the world literature, it's not too bad. It can be anywhere, because the different criteria used, inconsistencies of criterias, there are different prevalences in different geo-ethnic locations. Also, we learn to recognize primary Sjogren's as a systemic disease rather than dry eye and dry mouth. And the direct questioning of these two symptoms will miss out in the vast majority. We learned that. So currently, the modest estimate says about 0.5% of population have Sjogren's. So there is no community or hospital data. So Sapan again was a pioneer in that. In 2012, he organized the Iracon in Ahmedabad. So Ahmedabad was the capital of Sjogren's much before it became the political capital of India. The Sapan had asked our colleagues across India, can we generate data of Indian patients across various zones of India, north, south, east, west, like that. And I was given the responsibility to do that from South India. And because Vellore is a huge center with huge patients, I requested Dr. Sandhya, when she was working with us, to do that. And she did such a thorough job. And I presented that in Ahmedabad conference in 2012. So the objective was to present just a retrospective cohort just to create awareness and describe the clinical presentations and immunological profile and outcome in Indian cohort of Sjogren's. We looked at all the electronic medical records between 2004 and 2011, and both outpatient and inpatient, and we screened for patients and then we looked for if they fulfill the criteria. So that series of what was mentioned by Mr. Roy is that series of 332 patients of Sjogren's, purely the hard work of Dr. Sandhya, and we sent it to many journals and just got rejections after rejections. At one point, Dr. Sandhya was frustrated. What is this? They don't even believe, and some people don't even read our papers. And there is a, we Indians have earned a reputation of being fraudulent and, cooking up data. So they find it very hard to believe from all of a sudden from where the Indians are presenting Sjogren's. But finally, we got one index journal, but not very much well read by many people. So it was unnoticed even after we published it in 2015. But one fine morning in the same year, I found a letter from the International Big Data EULAR Sjogren's cohort from Dr. Ramos. And he asked me, can you join us? We read your paper. Can you join us in Sjogren's Big Data group? Dr. Sandhya said, sir, we should not miss out this opportunity. And today we are in the global Sjogren's map. So after that, we have really created awareness across India on Sjogren's syndrome, which SAPAN had contributed significantly. We strengthened it also. And this is a borrowed slide from Dr. Sandhya. So if we look at only dry eye or a dry mouth or neuropathy or dyspareunia or dry skin, we will all miss out Sjogren's. It's like 10 blind people trying to feel an elephant, and depending on what they feel, they will interpret differently. So there has to be a holistic approach towards Sjogren's syndrome. So it's not a disease of dryness, it's a complex and heterogeneous disease. It's a systemic disease, it's an autoimmune disease, and lots of B cell overactivity here. The lot of abnormal lymphoid cells infiltrate the glands and causing dryness. There are autoantibodies like Rho. And all of you know this lady. Why I put this slide? Because she suffers from Sjogren. So a champion also can be having Sjogren's. Thank you very much. This is my talk. And now I go back to inviting my other colleagues. The next will be Dr. Sandhya, and I would request Dr. Sandhya to give an overview of Sjogren's syndrome. And I must tell you today among the patients that it is not just the patients patients are not expected to know what disease they have. Then of course, that time has not yet come. Maybe one day artificial intelligence will rule the whole world and there may not be need of any doctor. But as of now, we need some people. And many doctors, I must tell you that rheumatologists, even today, they miss out Sjogren's syndrome and they don't believe it is Sjogren's syndrome. Forget about physicians and others. And Dr. Sandhya has done wonderful research in this direction, and it will be a pleasure to listen to her. Sandhya, please. Welcome you, and please deliver your talk.
Thank you, sir. Thank you for your kind words. And I would also like to thank Sjogren's India for the excellent work and for organizing this symposium. I'm very happy to be here today. And let me straight away start with the presentation. So I'll be presenting an overview. So first, let us talk about the facts. So as sir has already mentioned, this disease affects 0.5% of population. And in India, we have seen that women in age group 30 to 50 years are most affected. So if you compare with the Western data, our patients are affected a decade earlier. Men and children are also affected, but 10 times lesser as compared to women. Now, what is this? There are four main things we need to know about this disease. This is a long standing disease, it's a complex autoimmune disease, and the disease mainly affects the moisture producing glands. At the same time, as sir has already emphasized, this is a multi-system disease. What do we mean by a multi-system disease? This is a disease where various organs are affected. And this disease is underdiagnosed and misdiagnosed. So throughout over the next few slides, I would like to emphasize this aspect about the dryness, the multi-system aspect, and why this disease is underdiagnosed. Now, like I said, the moisture producing glands are affected, and the main moisture producing glands, if you look at here, these are the tear glands near the corner of the eye, and then you have, this is the salivary gland, this is a parotid gland, this is the submandibular gland, and there are many glands inside the mouth. So when these glands are affected, this can result in dryness of eyes, dryness of mouth, dryness of nose, dry throat, and dry skin. But most of the time, the patients don't come and directly say that I have dryness. Most of the time, what happens is we get to see the indirect effects. Patients have difficulty in swallowing dry food. There is inability to speak continuously, sore throat, hoarseness, changes in sense of taste, bad breath, burning sensation in the mouth, caries, premature loss of teeth. There is fungal infection in mouth. So many of these symptoms are vague and non-specific. So unfortunately, even if you tell your family
Excuse me,
members,
Dr. Sandhya. Excuse me, Dr. Sandhya. Are you using slides or are you not? Because we are not seeing them.
oh, I'm using slides. Sorry.
Should I share the screen? Should I
Oh,
share your PPT? Dr. Sandhya, should I share your PPT?
Sorry, I was not aware of this.
No, I'm just sharing it. No problem.
I will share. No problem.
Okay, fine.
How do I share this?
There is a share screen button.
Okay, fine. Sorry, I thought it was being shared. Sorry.
No problem. No.
Thank you for reminding. Sorry about that.
Yeah, if you could just put it on slide mode, it would be easier for us to see it.
Yeah, so
thank you.
Sorry, I wanted to show this diagram. So this shows the main salivary. This is just what I was talking about previously. This is the tear gland and these are the salivary glands. Okay, right. And then I was saying that many of the time patients don't directly come and say dryness of mouth and dryness of eyes. It takes some time to figure out that these things are happening. So most of the time patients have, the complaints are related to the indirect effects that they feel. And what happens is these symptoms are vague and non-specific, and these tend to be trivialized by your family members, by your physician. So it is a difficult journey. So here I would like to show how this can manifest. So sometimes the patients can feel that the mouth is quite dry, and then sometimes this can show the different presentation. So this slide, if you see the corner left, so the tongue is totally parched. Sometimes you can get cuts over the corner of the mouth, which is very painful. This condition is called angular cheilitis. So there is inflammation there, there is redness and soreness on the angle of the corner of the mouth. Then sometimes patients have burning sensation in the mouth, and this is most often due to fungal infection. So here you can see that there is a white curdy precipitate on the tongue. So this is due to fungal infection. It's a condition called oral candidiasis. So dry mouth alone does not cause burning. So when you feel dryness, and in addition to dryness, when there is a lot of pain, we should consider the possibility of a fungal infection. Then caries tooth. Very prematurely you start losing your teeth. Okay, so there is extensive caries and loss of teeth. And the other thing is there is gland swelling. So here I've previously showed you that this is the site of the parotid gland, and this gland can get swollen and enlarged. So many of the times patients come and tell us, I had repeated attacks of mumps. So this is nothing but another manifestation of Sjogren syndrome. Now, when the tear glands are affected, there is dry eyes, there is gritty eyes, feeling of sand in the eyes, itching, burning sensation, and redness. This disease can also cause dry nose. It can cause dry vagina, resulting in painful intercourse, which is called dyspareunia, and dry skin. Now, very important to remember, as already emphasized, this is not a disease of dryness alone. Any organ of the body can be affected as depicted in the figure on the left. Extraglandular disease is seen in up to 60%, Fortunately, in most cases, it is not very severe. Severe disease is seen in 5 to 10% of cases, and rarely lymphoma occurs in these patients. It is very important to emphasize that no two patients with Sjogren syndrome are alike. And it is not, and there is no stage by stage or stepwise progression. It is not that first you will have dryness, then you will have involvement of liver, then after a few years lungs. It doesn't work like that. So you can have randomly the other organs may or may not get affected. And the other important thing is that this other organ, the extraglandular organ involvement may not appear related to Zika symptoms. So that is the reason why many patients, when they come with neurological problems, say they come with a neurological problem or they come with a kidney problem, they may not mention Zika symptoms because they do not see how these things can be connected. You may be having Zika symptoms for a long duration of time and suddenly you will develop neuropathy. Or you may have neuropathy that happens first and Zika symptoms may happen later. So this is why when the Zika symptoms appear later on, this makes the diagnosis difficult and many doctors would not consider the diagnosis. So just to show the common organs that are affected, like I said, neuropathy is a common symptom. There can be pain and tingling sensation. Neuropathy can cause weakness. You may feel imbalance because of that. Lungs can get affected in many ways. One of the serious conditions that affects the lung is a disease called interstitial lung disease. The skin lesions, you can see red raised rashes. This is called a purpura. This is also a manifestation that is experienced by many. And the other thing that can happen is there is a condition which sir mentioned in the previous talk that is called hypokalemic paralysis. So what happens in this condition is the kidneys are supposed to maintain the balance between the potassium, salt, and the acid in the body. And when the kidneys fail to do that, in a condition called renal tubular acidosis, this results in hypokalemic paralysis, where patients have life-threatening paralysis, which can be, if identified, it can be corrected very easily. Now, however, the most common manifestations are this a condition called fibromyalgia, where you have pain all over the body. Patients feel extremely tired and there is extreme exhaustion and there is disturbed sleep. The joint involvement can cause pain and swelling of the joint, but generally, unlike rheumatoid arthritis, does not cause deformities. Now, this is from the research done at Vellore, and we looked at 275 patients where we had all the records, right from their first visit to the last till the time they were diagnosed. So what we found is that these 275 patients, at first visit, they went to 24 different specialties. So they had all these various symptoms, and it required from 1 to 14 hospital visits. So this was the number of visits we looked at. So it varied from 1. So some patients got diagnosed soon, and in some patients it required up to 14 hospital visits were required to make this diagnosis. And look at this. Zika symptoms were spontaneously complained by only 33 patients out of 275. That is just 12%. So if you look at causes for delay in diagnosis, one is variant presentation, less awareness among doctors, and patients with systemic features do not volunteer Zika, and unfortunately doctors do not ask. And the other reason for delay is no single test has 100% positive. There is no single test which can clearly say that this patient has Sjogren syndrome. Now, let us talk now about the lab test for diagnosis. Again, there is no single test. What we rely upon is a combination of clinical and lab features. So we, in a patient where we suspect whether the patient volunteers Zika or not, we need to do the test for dryness. So there are tests which can be used to demonstrate dryness of eyes. I'm sure many of you would have undergone this test. This test involves placing a filter paper in your eye and looking for wetting of the filter paper. Similarly, there is test to identify dryness of mouth, which involves spitting into a tube over 15 minutes and measuring the amount of saliva. The other blood tests are anti-SSA antibodies. This is what is included in the criteria. So this test is positive in 60 to 70% of patients. again, remember, this is not positive in 100%. So there are many patients where the antibody is negative. The other tests that are positive are anti-SSB, ANA, this is the anti-nuclear antibody, rheumatoid factor, RF, and increased ESR can be found without any reason. Patients say, I've been having increased ESR for a long time. This is again a clue for the diagnosis of Sjogren syndrome. Now, this is the salivary gland biopsy. Many of the patients are hesitant and afraid to a biopsy. It is a minor procedure. It requires only 10 to 15 minutes. So I'll just briefly try and explain what the procedure is. So this is the lower lip. So if you push your tongue on your lower lip and try to feel the lip, you can see some mounds of tissue. You can feel that. So these are nothing but the minor salivary glands. We give a local injection so that you don't feel pain when we do the procedure, and then we put a nick over those mounds, and these are the small glands that pop out, and then we can incise those glands, and this is sent for biopsy. So this is one important procedure which can confirm the diagnosis of Sjogren syndrome. Okay, the other modalities for diagnosis is, one is salivary gland ultrasound, which can be very easily done. In addition to that, MRI, and there are other imaging techniques, xylogram and scintigraphy. Now, I'll very quickly move to treatment. Now, in treatment of dryness, as you would have realized, self-care is very important. We need, for if you have dryness of eyes, of course, the doctor would prescribe artificial tears, and when the dryness is extreme and it is causing inflammation, steroid and cyclosporin eye drops are required. But what can you do from your side? Regular eye checkup is important. Use moisture chamber glasses. Avoid direct air on eyes. Avoid air conditioned air on eyes. Cover eyes whenever you are going to a windy area or when you're traveling on a two-wheeler. And it is important to decrease screen time, blink frequently, and use sufficient light while reading or writing, because it can be very irritating to read or write in less light. And for dry mouth, use salivary substitutes, sugar-free candies, chewing gum containing xylitol. So there is something called oil pulling. This is nothing but using oil and swishing in your mouth, just like a gargle. You can gargle. And the most frequent oil which has been found to have benefit is virgin coconut oil. So this involves using like 1 tablespoon of oil the first thing in the morning on empty stomach, and after you have done with your swishing, spit it out, and then you can rinse your mouth and then brush your teeth. So when you brush, one important thing is use SLS free toothpaste. This SLS is a component which is used to make the toothpaste very foamy. So many patients, while that gives a feeling of freshness, otherwise for patients with dryness, this can be very irritating. So look for SLS. This is one tip that I can give. You try to use SLS free toothpaste. Almost all the major brands would have an SLS free toothpaste as well. Sensodyne has it. And the other thing is to prevent caries. So those with Sjogren's have, that is because the saliva quality is less and the quantity is less, the quality is also affected. This can lead to caries. So you need to take precautions to prevent caries tooth, avoid sweetened food, use an alcohol-free mouthwash, and get your visits regular with the dentist. And the dentist would recommend high fluoride toothpaste or neutral pH sodium fluoride gel in case you have caries. And pilocarpine is a useful drug to cause your glands to stimulate. I said the glands are affected, and the glands can be given an extra stimulus to secrete by using this drug called pilocarpine. Now, pilocarpine is in short supply, and what I tell my patients is, if they are unable to procure the tablet, pilocarpine eye drops 4% strength is available, and 3 drops could be equivalent to 5 milligrams. So what you could do is, in half a glass of water, you can put 3 to 4 drops and drink this 2 times a day or thrice a day. Okay, now let us talk about dyspareunia. So this can result in painful intercourse, and if you have dry vagina, you can apply Lubic jelly or KY jelly. This is widely available. However, if there is persistent pain or this doesn't help, please consult the gynecologist, because you may be having infections or there can be other gynecological problems which could be contributing to dyspareunia, such as endometriosis or some infection. You can consult your gynecologist whether you can apply Premarin. Premarin is a local estrogen cream that can be applied locally. Now, the other very debilitating feature is fibromyalgia and fatigue. So, when a patient complains of fatigue, we try to look for correctable causes. So, other than Sjogren's, whether the patient has other causes for fatigue, such as vitamin deficiency, say you have vitamin B12 deficiency, vitamin D deficiency, and sometimes the condition that I have mentioned, that is that affects the kidney, and you have renal tubular acidosis, there because of electrolyte disturbances, you can have fatigue. So the doctor, your rheumatologist will certainly look for these causes. Then the other thing is adequate sleep is very important. We have to try and minimize stress in our lives. Lifestyle changes. So lifestyle changes such as having aerobic exercises regularly, yoga, meditation, and then of course there are medicines that can be used for treating fibromyalgia and fatigue. Now, talking about treatment of systemic disease, so most important in treatment of systemic disease is regular physical examination by the doctor. Lab investigations have a supportive role. So when we look, as a rheumatologist, when we look at Sjogren's patients, so when we examine it, each visit, what we look for is whether the patient has fever, weight loss. So recording your weight regularly is very important. We look for lymph nodes. We look if your glands are swollen. We look at your joints. We look at the skin. We auscultate the lungs. We see whether the urine examination is abnormal, whether your electrolytes are abnormal. That could indicate a kidney problem. Whether you have more protein in your urine, whether your muscles are affected, whether you are able to feel the sensation normally, whether there are symptoms that indicate that your brain is affected. Then we do a supportive lab investigation, and the other tests which give a clue are C3, C4, and globulin. So what we do is the medications are tailored to the organ involvement. All patients do not get the same medicines. So there is a personalized plan that is made. All patients do not need steroids. Most of you may be on HCQ. So based on the organ involvement, you may be on immunomodulators, that is methotrexate, drugs like methotrexate, leflunomide. Immunosuppressive may be required in some patients. So these are drugs like mycophenolate, azathioprine, cyclophosphamide, cyclosporin, tacrolimus, and some patients may get rituximab, which is a biological agent which blocks the B cells that produce the abnormal antibodies in Sjogren's. Let me tell one thing. Many patients are worried about the ANA being positive, anti-SSA being positive. Please do not be worried. The repeated test, that is ANA and anti-SSA, and looking at whether it is coming down, are not of any value. And please don't get worried with the test being persistently positive. We are concerned in you getting better, not the lab test getting better. So the points to remember is regular follow-up is important, and inform rheumatologists regarding all medicines you are on. Why I emphasize this is sometimes I write medicines and I know that the patient is not taking the drugs. So many of the time patients are very hesitant to tell if they are not taking the medicine. So it is very important to have a communication. And if you're not taking, please tell us that I'm not taking, I do not like this drug, or I'm having this adverse effect. The other important point is you may be taking drugs prescribed by other doctors. It is important to share your other diagnosis. So many a time, patient may come to rheumatologist and tell about the joint problem only. They may not feel it necessary to convey that they are meeting neurologist for some other disease. So this may actually be connected. So that is why I'm saying it is very important to, sometimes you may be going to nephrologist and neither the nephrologist will know about Sjogren's, neither the rheumatologist will know about the kidney problem. So very important to inform the doctors that you are consulting about the different diagnosis and the different medicines you are taking. Inform other physicians regarding diagnosis. So let me say an example. You may be having an allergy. Many of the allergic medicines can increase your dryness. So if you inform, then the doctor will prescribe a drug which is least likely to exacerbate your dryness. And like I said, list all your symptoms at every visit. Please keep a diary. So it is important so that you can very promptly say that these are my symptoms and this is the date from which I've been experiencing this symptom. And very important to know, all patients with Sjogren's do not have the same journey. Your journey is unique, and all patients may not respond similarly. And the adverse effect of medicines, what you experience, somebody else may not experience. And very important that you do not discontinue the medicines without discussing. See, some patients may take methotrexate for 2 weeks, they do not see any response, so they will stop. So if you discuss with your doctor will tell you this medicine takes time to act. It would take at least 2 to 3 months to know whether methotrexate or HCQ is working or not. So very important, have an open discussion with your doctor, and before you decide to discontinue, discuss, make a combined decision, and then discontinue. Okay. So the other thing I want to say about pregnancy. So most of our patients are female. So we need what I would like to emphasize is the pregnancy need to be planned. It should not be an emergency. So always plan your pregnancy, discuss with rheumatologist what would be the right time to be pregnant, and so then you can plan your medicine. So there are many medicines which are safe during pregnancy and lactation. So generally, pregnancy is advised once your disease is under reasonably good control. And please do not make the mistake of discontinuing all the drugs and becoming pregnant without informing your treating doctor. There are drugs which are safe during pregnancy and lactation. You can be put on those drugs. And pregnancy related issues are rare. So if you read the literature, you will see that there are complications. And what I want to say is, these are very rare. Most of you will have a pregnancy without these complications. And if you already had a prior pregnancy without complication, risk in the subsequent pregnancy is very rare. And the other thing patients are concerned about is that I have this disease, I am on these medicines, will I pass on this disease to my child? So that is very, very, very rare. I have seen families with mother and sister affected, and it is very, very rare to have a mother and daughter with the same disease. So I think it is we should check with Sapan sir and Danda sir as well, but this is very, very rare. So do not worry about this. And the other thing what I want to say is the main thing, the event, if it happens, it is very rare, and this is called the fetal heart block, and this is seen in patients who are antibody positive. So patients with antibody negative need not worry, and even those who are antibody positive, this is very rare. What happens is your antibody crosses from your body to the placenta to the fetal heart, and it can cause fetal heart block. If you had a baby with this condition previously, then in subsequent pregnancy we need to be more cautious, and we need to discuss with the rheumatologist prior to planning your pregnancy, and we need to see what can be done to prevent. So one thing which can prevent, which has been seen in very recent studies also, HCQ can decrease the occurrence of fetal heart block. And remember, HCQ saved. I'm emphasizing this because many of my patients have discontinued HCQ during pregnancy. So please remember, HCQ is safe, and taking HCQ can decrease the incidence, it can reduce the incidence of fetal heart block. So those who are at risk need to monitor for fetal heart. You should discuss with your doctor how this can be done. And the maximum risk happens between 16 to 24 weeks of pregnancy. And in case this happens, there are drugs which can be of benefit. I would just like to check whether I'm running out of time. Shall I stop here and maybe we can discuss other things later on?
If you have a few more slides, how many more? 1 or 2 slides more? You can finish.
Yeah, I just want to explain
please,
I can do that later
please
also.
Please finish it off, no problem.
Okay. So the other thing which most people want to know is what is an autoimmune disease, and how to explain this autoimmunity. So let me try to explain this. So this is the human body. Okay. Now the immune system works like a security guard. So imagine you have a security guard. So that guard will protect you against enemies, let us say a terrorist, or let us say in this case, it is the bacteria. The immune system has to protect you against bacteria and virus. So the immune system fires only if there is bacteria or virus. And this is what happens in a normal functioning body. The immune system should not fire when there is no bacteria or virus, or when there is no threat. But in a patient with autoimmunity, what happens is the immune system gets corrupted. the same immune system which is supposed to protect you wrongly starts firing against your own body. Now, this is what happens in autoimmunity. Now, just to explain, take it a bit further, see, what happens is in Sjogren syndrome, the target organ that gets affected, they are cells called epithelial cells. These are there all over the body. These epithelial cells form your moisture producing glands, and it lines all the major organs. That is why this disease affects the glands and the internal organs. Now, what happens is, what they are firing is the WBC. So you have this abnormal WBCs, the white blood cells which are supposed to protect you, that is your immune system, and these immune system produce antibodies. In normal situation, they are protective antibodies, but in this situation, they are abnormal antibodies, which are, these are the bullets. Like you can imagine that WBC is the gun, and the bullets are these antibodies, that is rheumatoid factor, anti-SSA, and anti-SSB. So the other thing what I'm asked regularly is, what causes autoimmunity? In a single word, we do not exactly know why you have Sjogren's. There are a combination of factors. These may be genetic, these may be infections, toxic chemicals, and dietary factors. So I think I will stop here, and I think other questions will be addressed by the other panelists during the QA session and myself. Thank you so much for listening, and back to you, sir.
Thank you. I think now, Mrs. Kirtida, we have a 5 minutes, just 5 minutes break. People to stretch, maybe moisturize your mouth.
Or we can just quickly have a recap in Hindi by Dr. Sapan, and then take the break.
Dr. Sandhya, could you please stop your screen share? Thank you.
Should I? Thank you. Thank you, Sjogren's India, Kirtida Oza, Danda sir, Sandhya, and Dr. Kurian. I see him, senior from doctor from Vellore, and the others. So let me quickly, before we go to the break, हिंदी में काफ़ी लोग हिंदी में बोलने वाले होंगे, तो उनके लिए मैं ट्राई करता हूँ. वैसे तो हमारा हिंदी कोई ख़ास नहीं था, लेकिन हम फिर लखनऊ गए तो वहाँ थोड़ा सीख के आए हैं, तो आई होप कि, लेकिन फिर भी अंग्रेज़ी शब्द तो थोड़े आ ही जाएंगे. आई थिंक सब समझते हैं. तो डॉक्टर संध्या ने, डॉक्टर देबाशिष डाना ने पहले अपना एक ओवरव्यू दिया हिस्ट्री का, शोग्रेंस किस तरह से, एंड अपना व्यू उनका, कहाँ पे उन्होंने ट्रेनिंग ली थी उसके बारे में बताया. एंड देन डॉक्टर संध्या ने काफ़ी चीज़ें बताई जो आपके लिए काफ़ी, कुछ चीज़ें तो आपको पता होंगी, लेकिन जो उन्होंने बताया मैं एक संक्षिप्त में ट्राई करता हूँ कि मैं आपको बताऊँ. तो शोगरेन सिंड्रोम जो है एसेंशियली ये जिस तरह आप लोगों को पता ही है और आप खुद भी सफ़र हो ही रहे हो, तो इसमें ड्राइनेस रहती है, मुंह में ड्राइनेस और आंखों में ड्राइनेस, खुश्की रहती है बहुत. और जैसे मैं मेरे मरीज़ों को पूछता हूँ कि आपको इतनी खुश्की रहती है कि आपको कुछ भी खाना हो तो वो पानी पी के लेना पड़ता है, इतनी ज़्यादा ड्राइनेस रहती है. आंखों में खुश्की, जैसे डॉक्टर डांडा ने बताया कि 10 साल तक कंटिन्यूस आई ड्रॉप्स कुछ मरीज़ डालते हैं. तो जब आपके डॉक्टर आप आँख के लिए चेकअप के लिए जाते हैं और बताते हैं कि ड्राइनेस है, तो ये नहीं है. ड्राइनेस की तो कई सारी वजह है, शोगरेंस उसमें से बहुत कम लोगों में देखा जाता है. लेकिन एक चीज़ है जो आपके फ्रेंड्स अगर कोई बताते हैं तो ठीक रहता है कि आप अपने डॉक्टर को बताएं कि शोगरेंस सिंड्रोम के लिए, बाकी सिम्टम्स के लिए भी देखा जाए. और जैसे कि उन्होंने अपने डॉक्टर देबाशिष डांडा और डॉक्टर संध्या ने अपनी वेलोर की सीरीज़ पब्लिश की थी जर्नल में, जिसमें करीब 275 या 334 पेशेंट थे शोगरेंस के, जो शायद मेरे हिसाब से सबसे बड़ा आंकड़ा होगा शोगरेन सिंड्रोम किसी एक सेंटर का. वेलोर जैसे आप जानते हो बहुत बड़ा सेंटर है और वहाँ कई मरीज़ आते हैं. उसमें उन्होंने देखा कि मरीज़ अपने आप, केवल 12% मरीज़ ने अपने आप बताया कि हमें ड्राइनेस है, खुश्की है. बाकी तो ये एक चीज़ रहती है कि बिकॉज मरीज़ यूज्ड टू हो जाता है. हमें याद है हमारा भी जो एक मरीज़, एक बहुत ही पुराना मरीज़ जब भर्ती था आईसीयू में और उनको पोटेशियम कम हो गया था और पैरालिसिस टाइप हो गया था पैरों में, तो उन्होंने, जब मैंने उनको पूछा तब तक वो डायग्नोज नहीं हुए थे, लेकिन चूँकि पोटेशियम कम हो जाता है और पैरालिसिस होता है किडनी में असर की वजह से, जो डॉक्टर संध्या ने बताया किसी मरीज़ को शोगरेंस में, तो मैंने उनको पूछा कि आपको ड्राइनेस है, तो बोलते हैं सर मैं 10 साल से बोल के थक गई कि मुझे ड्राइनेस है, लेकिन आइडिया नहीं था. तो ये बाद में हम बताएंगे किस तरह इसकी अवेयरनेस स्प्रेड की जा सकती है हम डॉक्टर्स में भी। लेकिन सो ड्राइनेस इज़ द मेन थिंग जो करीब मोस्ट पेशेंट्स को 80-90% को तो रहता ही है। कुछ मरीज़ों को आजकल टेस्ट की वजह से पहले पकड़ में आ जाता है ड्राइनेस के पहले बीमारी के बारे में, लेकिन मेजॉरिटी को ड्राइनेस रहता है। इसके साथ पैरोटिड माने गलसुआ जो बोलते हैं वो हो जाता है, पैरोटिड एनलार्जमेंट। अच्छा, मम्स जो होता है वो तो बचपन में वायरस की वजह से होता है, लेकिन अगर आपको बड़ी उम्र में 30, 40, 50 की उम्र में अगर बार बार पैरोटिड ये गलसुआ हो रहा है तो उसकी वजह शोगरेन्स भी हो सकती है। कुछ और बीमारियां भी हैं, लेकिन आप आपके डॉक्टर को बताएं, या आपके अगर कुछ फ्रेंड्स बोल रहे हैं इस तरह का हो रहा है तो शोगरेन्स के लिए वर्कअप होना चाहिए। तो पैरोटिड एनलार्जमेंट, ड्राइनेस हमने बताया। अच्छा, कई बार ड्राइनेस दांतों की खराबी की तरह से होता है, डेंटिस्ट के पास जाते हैं, मरीज़ को इतना ड्राइनेस नहीं लगता है लेकिन उनके दांत बार बार ख़राब हो रहे हैं, दैट इज़ बिकॉज क्वालिटी ऑफ सलाइवा पुअर हो जाता है, तो इसमें ये भी रहता है। और फिर कुछ मरीज़ों को ये मेन सिम्टम्स, जॉइंट पेन्स भी रहते हैं ऑलमोस्ट 60-70% को, जिनकी सीरीज़ थी वेलोर की सीरीज़ में सबसे ज़्यादा मस्कुलोस्केलेटल प्रॉब्लम्स, मतलब मांसपेशियों और जोड़ों का दर्द, जिसकी वजह से रूमेटोलॉजिस्ट पिक्चर में आते हैं, गठिया जैसा प्रेजेंटेशन होता है, सुबह के टाइम पे अकड़ जाते हैं, तो ये जॉइंट पेन्स भी एक प्रॉब्लम रहता है। ये 4 चीज़ें करीब 70-80% पेशेंट में तो रहती ही हैं। पैरोटिड ऑफ कोर्स कम में होती है थोड़ी, लेकिन ड्राइनेस और अच्छा, दूसरा कॉमन सिम्टम है फटीग, थकान बहुत रहती है इन मरीज़ों को, तो फटीग इज़ अ प्रॉब्लम। स्लीप इश्यूज़ रहते हैं, नींद की, पेन्स रहते हैं, एक्स एंड पेन्स, फाइब्रोमाइल्जिया बताया उन्होंने, कई बार कंधे की जगह पे पेन्स रहते हैं इनको। ये सारे बड़े कॉमन सिम्टम्स हैं। फिर होते हैं एक्स्ट्रा ग्लैंडुलर कॉम्प्लिकेशंस, मैंने करीब चूँकि ये बीमारी इम्यून सिस्टम की, मैंने रोग प्रतिरोधक शक्ति की बीमारी है, करीब सारी सिस्टम्स और ऑर्गन्स इन्वॉल्व हो सकते हैं इसमें। अगर हम ऊपर से शुरू करें तो स्किन में रैशेस तरह तरह के होते हैं, किसी को यहाँ लाल लाल हो जाता है जब ल्यूपस ओवरलैप होता है, कुछ मरीज़ों को आइज़ का हमने बताया कि ड्राइनेस रहती है, पैरोटिड्स के बारे में बताया। फिर अगर फेफड़ों में जाए तो इंटरस्टिशियल लंग डिजीज़ रहता है, सांस में परेशानी होती है, कुछ मरीज़ों को अस्थमा टाइप प्रॉब्लम भी रहता है, इसमें खांसी रहती है, ड्राइनेस होती है, इसको सिक्का बोलते हैं अगेन लंग्स में। फिर हार्ट में भी बहुत रेयरली असर लेटर ऑन होती है कुछ मरीज़ों को। फिर नीचे जाए तो लिवर में इसके साथ हेपेटाइटिस भी हो सकता है, कई बार ऑटोइम्यून हेपेटाइटिस ओवरलैप होता है कुछ मरीज़ों को। लेकिन ये सारे सिम्टम बहुत कॉमन नहीं है, करीब 10, 20, 30% मरीज़ों को होता है। रेनॉल्ड्स होता है जिसमें उंगलियां सफ़ेद नीली पड़ जाती हैं, तो वो भी एक, यहाँ पे कई बार घाव हो जाते हैं। कभी कभी इन मरीज़ों को स्क्लेरोडर्मा ओवरलैप, एक और बीमारी इसके साथ स्क्लेरोडर्मा टाइप की होती है, उसकी भी असर होती है, जिसमें स्किन टाइट होती है। फिर पेशाब, इंटरस्टिशियल सिस्टाइटिस, किसी को बार बार पेशाब जाना, पेशाब की जो उसकी ब्लैडर है उसमें थोड़ा सूजन रहता है। अच्छा, प्रेगनेंसी के बारे में डॉक्टर संध्या ने बताया कि चूँकि इसका एंटीबॉडी जो इन मरीज़ों में रहती है वो प्लेसेंटा को क्रॉस करके बच्चे में जा सकती है, हार्ट में दिक्कत कर सकती है। लेकिन इम्पॉर्टेंट चीज़ ये है कि वो केवल 2% मदर्स को होता है। अगर आपको पहले हुआ है तो फिर 18-20% में होता है, लेकिन पहली बार अगर आपका रो एंटीबॉडी पॉजिटिव और प्रेगनेंसी है तो केवल 100 में 2 मरीज़ों को वो एंटीबॉडी प्रॉब्लम करती है, ज़्यादातर को नहीं करती है, तो ये इंपॉर्टेंट है जानना। फिर इंटेस्टिनल इश्यूज़ भी हो सकते हैं इसमें, कभी कभी वैस्कुलाइटिस होता है जिसमें घाव हो जाते हैं पैरों में, या जो नॉन हीलिंग टाइप अल्सर्स रहते हैं, लेकिन ज़्यादा कॉमनली हमने जो 2 मरीज़, और आई एम श्योर डॉक्टर डांडा की तो सीरीज़ है, डॉक्टर संध्या ने भी देखे होंगे, जो 2 चीज़ें अपार्ट फ्रॉम ड्राइनेस हमने ज़्यादा देखी हैं, वो एक तो है पोटेशियम कम हो जाता है, उसकी वजह से पैरों में वीकनेस सिवियर हो जाती है, पैरालिसिस टाइप हो जाता है, जिसको हम कहते हैं हाइपोकैलेमिक पीरियोडिक पैरालिसिस, बार बार पोटेशियम कम होने से। और पोटेशियम कम इसलिए होता है कि इन मरीज़ों को किडनी में इफेक्ट होता है। उसकी डिटेल में न जाते हुए, इन मरीज़ों का एसिड ब्लड में बढ़ जाता है, उसकी वजह से पोटेशियम गिरता है और फिर पैरालिसिस टाइप होता है। ये करीब हमने एटलीस्ट 20-30% मरीज़ों में देखा। नेफ्रोलॉजिस्ट ज़्यादा देखते हैं ये प्रॉब्लम। और दूसरा, पैरों में चकत्ते पड़ते हैं, जिसको हाइपर गामा ग्लोबुलिनिक परप्यूरा बोलते हैं। जब खड़े रहते हैं, हमारे मरीज़ कहते हैं कि सर जब मैं खड़ी रहती हूँ तो मुझे चकत्ते आ जाते हैं पैर में, शुरुआत में ऐसा था, अब तो पूरे बदन में चकत्ते आने लगे हैं, लेकिन शुरुआत में पैरों में आते हैं और जब मैं लेट जाती हूँ तो चकत्ते निकल जाते हैं। ग्रेविटेशनल परप्यूरा होता है इन मरीज़ों को, क्योंकि उनका प्रोटीन ग्लोबुलिन टाइप का बड़ा हुआ रहता है ब्लड में, उसकी वजह से होता है। ये 2 प्रॉब्लम हमने कुछ ज़्यादा देखे हैं इन मरीज़ों में, मतलब करीब 20-30% में। सबसे ज़्यादा कॉमन तो जैसे बताया कि ड्राइनेस और यही है। तो ये करीब सिम्टम कॉम्प्लेक्स पूरा हो गया। कुछ को पेरिफेरल न्यूरोपैथी होती है, मतलब झंझनाहट हाथों पैरों में, बड़ी ट्रबलिंग होती है किसी को, मतलब चलना भी मुश्किल हो जाता है। एटेक्सिया जो बताया डॉक्टर संध्या ने, मतलब चलने में दिक्कत होती है, ऑलमोस्ट गिर पड़ते हैं, इस टाइप का भी न्यूरोपैथी किसी को हो सकता है। अच्छा, ब्रेन में कभी कभी डीमाइलेटिंग लीजन्स होते हैं, वो भी एक तरह का पैरालिसिस टाइप कभी कभी हो जाता है, और अगर ब्रेन का एमआरआई किया जाए तो उसमें भी दिक्कत आती है। तो इस तरह से करीब करीब सारे कॉम्प्लिकेशन हमने बता दिए। शोगरेन सिंड्रोम की इंपॉर्टेंस इसलिए रहती है कि कुछ मरीजों को इसमें से जिनको बार बार पैरोटिड हो रहा है या जिनका ईएसआर ब्लड में बहुत ज़्यादा है, उनको लिम्फोमा हो सकता है। एक तरह का कॉम्प्लिकेशन होता है, एक तरह का आप समझ लीजिए ब्लड कैंसर होता है, लेकिन बड़ा स्लो ग्रोइंग ब्लड कैंसर होता है। ये 10 साल तक चल सकता है, 15 साल तक, इसमें कोई हाई रिस्क नहीं होता है। लेकिन इस कॉम्प्लिकेशन की वजह से जो 10-20% मरीज को ये प्रॉब्लम होता है, उनमें ये रोकना ज़रूरी हो जाता है। तो ये रही सिम्टम की बात। डायग्नोसिस के लिए डॉक्टर संध्या ने बड़े अच्छी तरह से फोटोग्राफ से बताया। एक तो आपको प्रॉब्लम हो तो आप डॉक्टर्स को बताइए, वो आपका ये जानने ला बहुत ज़रूरी है कि ज़्यादातर ये सिम्टम्स ड्राइनेस के शोगरेन सिंड्रोम के सिवा के कारणों की वजह से ज़्यादा होते हैं। मतलब ड्राइनेस इतनी कॉमन चीज़ है कि शोगरेन सिंड्रोम उसमें बहुत कम प्रोपोर्शन में देखा जाता है, लेकिन अवेयरनेस होनी चाहिए। तो हर एक ड्राइनेस कोई शोगरेन्स नहीं होता, ये जानना ज़रूरी है, मैं ये कहना चाह रहा हूँ। कभी कभी एंटी डिप्रेसेंट ड्रग्स की वजह से भी ड्राइनेस कॉमन है, डायबिटिक्स को ड्राइनेस रहती है, तो ये ज़्यादा कॉमन रीजंस है। तो आपके डॉक्टर आपका क्लिनिकल डायग्नोसिस बनाएंगे, उसके आधार पे इन्वेस्टिगेशंस करेंगे। ENA टेस्ट एक होता है जिसमें एंटी रो 70% में पॉजिटिव आता है। ये भी जान लेना ज़रूरी है कि आप अपने आप से टेस्ट मत करवाइए प्लीज़, बिकॉज जैसे डॉक्टर संध्या ने बहुत अच्छी तरीके से बताया कि हम टेस्ट की ट्रीटमेंट कभी नहीं करते हैं, हम मरीज़ों की और उनके लक्षण की ट्रीटमेंट करते हैं। टेस्ट आपके पॉजिटिव हो सकते हैं, लेकिन आपको लक्षण नहीं हो तो उसका डायग्नोसिस नहीं बनता है। तो आप अपने आप से टेस्ट मत करवाइए, लेट योर डॉक्टर ऑर्डर दीज टेस्ट। ये कॉस्टली टेस्ट भी होते हैं कुछ, तो करवाना ठीक भी नहीं है मेरे हिसाब से। तो एंटीबॉडी जैसे 70% पॉजिटिव ENA हो गया, रोमेटॉइड फैक्टर ज़्यादातर को पॉजिटिव आता है, ESR किसी किसी को ज़्यादा रहता है, आपका किडनी ब्लड का टेस्ट तो डॉक्टर करवाएंगे ही, और बायोप्सी किसी किसी को ज़रूरत पड़ती है, इसमें सलाइवरी ग्लैंड बायोप्सी लेते हैं। अच्छा, आई के लिए शर्मास टेस्ट ऑप्थेल्मोलॉजिस्ट करते हैं, जिसमें एक फिल्टर पेपर डालते हैं, हाँ उसमें देखते हैं कितने आंसू के कुछ टेस्ट होते हैं, आंसू बनने के नहीं। सलाइवा के टेस्ट भी डेंटिस्ट करते हैं। एंड देन आजकल सोनोग्राफी करते हैं पैरोटिड्स की। कई बार आपका पैरोटिड एनलार्जमेंट नहीं दिखता, लेकिन सोनोग्राफी में पकड़ में आता है। तो ये सब आपके डॉक्टर एडवाइस करेंगे, और इसकी एक्सपर्टीज बढ़ रही है, लोग कर रहे हैं। एंड देन कभी कभी CT स्कैन चेस्ट की ज़रूरत पड़ती है लिम्फ नोड्स देखने के लिए, और बायोप्सी ये लिप में से ली जाती है, होठ में से इनर अंदर की साइड में, वहाँ पे छोटी छोटी ग्लैंड्स होती हैं बहुत सारी, जहाँ से हमारा सलाइवा मने जो थूक बनता है उसकी बायोप्सी ली जाती है, और उसमें फिर डायग्नोसिस कन्फर्म्ड होती है कि यह है। तो कुछ कॉन्स्टिलेशन, हर एक को बायोप्सी की आजकल ज़रूरत नहीं पड़ती है। अगर आपके सिम्टम्स, आपके डॉक्टर आपका डायग्नोसिस बनाएंगे, मोस्टली रोमेटोलॉजिस्ट रहते हैं, लेकिन कभी कभी नेफ्रोलॉजिस्ट और न्यूरोलॉजिस्ट के पास भी ये केस जाते हैं। तो इस तरह से डायग्नोसिस बन गई, उसके बाद ट्रीटमेंट। तो ट्रीटमेंट जो है मोस्टली तो ड्राइनेस के लिए लोकल ऑइंटमेंट्स वगैरह जो आँख के डॉक्टर आपको देंगे, वो ड्राइनेस के लिए तरह तरह के ऑइंटमेंट्स आते हैं। जितना आपका ड्राइनेस है उतने हिसाब से तीव्रता उन दवाइयों की रहती है। मैं बहुत डिटेल में तो नहीं जाऊंगा कौन से वो यूज़ करते हैं। और इसी तरह से डेंटिस्ट ज़्यादातर आपके दांतों की भी ट्रीटमेंट देते हैं, या पेस्ट देते हैं जो आप लगा सकते हो। डॉक्टर संध्या ने कुछ पेस्ट की बात की कि ज़्यादातर प्रिजर्वेटिव फ्री ऑइंटमेंट्स रहते हैं ये सब आँखों में। एंड देन किसी किसी मरीज़ को सिस्टमिक ट्रीटमेंट, मतलब जिनको और जगह पे फैल गया है बीमारी, उनके लिए ड्रग्स इस्तेमाल करते हैं। वो ज़्यादातर हम रोमेटोलॉजिस्ट लिखते हैं, जिसमें हाइड्रोक्सीक्लोरोक्विन करके ड्रग है जो हम ज़्यादातर मरीज़ों को देते हैं। जैसे डॉक्टर संध्या ने बताया कि ये दवाई एंटी रो पॉजिटिव मदर्स को भी आजकल दे रहे हैं, ताकि बच्चे में वो हार्ट ब्लॉक प्रिवेंट हो जाए। इसका भी अब एविडेंस आया है। एंड इम्यूनोसप्रेशन मैंने स्टेरॉइड्स और आगे की दवाइयाँ जो उन्होंने बताई, कुछ इम्यूनोसप्रेशंस, रिटुक्सिमैब वगैरह, ये आप समझ लीजिए बहुत कम मरीजों को ज़रूरत पड़ती है। 70-80% पेशेंट्स कैन बी मैनेज्ड, वो मैनेज हो जाते हैं सिर्फ लोकल ऑइंटमेंट से और माइल्ड दवाओं से। लेकिन 20-30% मरीज़ जिनको कि ESR हाई रहता है, जिनको ये पैरोटिड्स बार बार हो जाते हैं, मम्स मतलब ये गलसुआ बार बार हो जाता है, जिनको परप्यूरा है पैरों में, इन मरीज़ों को जिनको कि लिम्फोमा होने की संभावना थोड़ी ज़्यादा रहती है, उनको कभी कभी, या न्यूरोपैथी बहुत डेवस्टेटिंग है, उनको हमें इस तरह की दवाइयाँ इम्यूनोसप्रेसेंट देने पड़ते हैं। मेजॉरिटी सिर्फ लोकल ऑइंटमेंट्स वगैरह से कवर हो जाते हैं। तो इतनी बातें हैं मेरी समझ से, ये इतना जान लेना ज़रूरी है। उन्होंने समरी भी अच्छी खासी दी कि आपको नियमित दवाइयाँ लेनी है, नियमित डॉक्टर का फॉलोअप रखना है। आई डोंट थिंक, मतलब इन अपने में रखें, अपने डॉक्टर से कंप्लेन के बारे में बताएं जो भी आपकी हो। आपको ऐसा लगेगा कि ये सिम्टम्स रिलेटेड नहीं है, लेकिन वो बेहतर है कि आपके डॉक्टर तय करें। कई बार अनरिलेटेड सिम्टम्स हमें पता होता है कि रिलेटेड होते हैं, तो आप अपने डॉक्टर से सारी बातें बताएं। इसके बारे में डरना बिल्कुल ज़रूरी नहीं है। शोगरेन्स आजकल काफ़ी अच्छी बात यह है, डॉक्टर डांडा विल एग्री, आई एम श्योर डॉक्टर संध्या विल ऑल्सो एग्री, जब मैंने शुरू की थी प्रैक्टिस 15 साल पहले, तब शोग्रेन्स का डायग्नोसिस करीब 5, 8, 10 साल बाद होता था। लेकिन आज इतने जल्दी मरीज़ रेफ़र हो रहे हैं, मतलब 2-3 साल में, और इतने जल्दी कि कभी-कभी मुझे बोलना पड़ता है कि इसके अभी तो क्राइटेरिया ही नहीं बन रहे हैं, मतलब फुलफ़िल हो रहे हैं। इतना जल्दी डॉक्टर्स भी अवेयर हो गए और वो भेज देते हैं हमारे पास। पोटेशियम गिर गया, एएनए करवा दिया, पॉजिटिव आ गया तो रूमेटोलॉजिस्ट को बुलाइए। तो अब काफ़ी अच्छा इसका फ्यूचर है मेरे हिसाब से। डायग्नोसिस भी जल्दी हो रही है, एंड आई सी नो रीज़न कि जितना जल्दी हम लोग डायग्नोसिस मिल के बना पाएंगे, उतनी अच्छी क्वालिटी ऑफ लाइफ आप लोग जी पाएंगे। तो आई थिंक विद दैट मैं उसके साथ अगर कोई क्वेश्चन बाद में रहेगा तो हम आई बी रेडी टू आंसर दैट। थैंक यू।
थैंक यू सपन, बड़ी अच्छी तरीके से हिंदी में समझाया आपने। So, is Mr. Soja, should we take a 5 minutes break for stretching?
Yes, Dr.
Okay. After that, we'll start with Dr. George Kurian's talk. Is that right? In the program, it shows Dr.
Yeah.
George Kurian's talk. No, first is your study. You have your study first. Yeah, there is a studies done by the Sjogren's India on patients, and they have generated some important data. So it's very interesting. So that data will be presented by Dr. Kirtida's team, and after that, Dr. George Kurian will be speaking. Thank you for your patience. You'll be back in 5 minutes. Is that right?
Mr. Roy, can you announce exactly when we are getting back? Because we're
6:30.
already running behind schedule, so we'd like to
6:30 on the laptop. That should be not on the watch.
6:30, please.
Okay.
Yeah.
So while we are gone for a break, I'm just playing this video by Sunila, and it's a flower and music show. And it's one of our Sjogren members who's has this beautiful garden, horticultural. We are just playing this video till we are all back.
Yeah, it's time. It's now 6:31.
Mr. Roy, tell me when you are all ready.
Yeah.
Should we start now, Mr. Roy?
Yeah, we can. It's already 6:32.
Yeah, please. Just announce.
Yeah. So
Yeah, I request Dr. Krisita Oza and Radhika to make a presentation on the patient's perspective, study findings, and patient interviews.
Hello. Can you see me and hear me?
Yeah, presentation is not there. Yeah.
Okay, I will just share screen. Is that visible now?
Yeah.
Kirtida, you may want to put it on top.
Yeah, I did. So thank you all for being here. And I'm very excited to share the findings of this first ever patient study that patients have done on their own. I'm sure the doctors will have a lot to say about the study. We just wanted to do an indicative study of what the patients felt about Sjogren syndrome. I realized that we will need to do a much more in-depth study, and we will, of course, follow this up with, but we just wanted to do a study to do a kind of, which would give us a guideline to how to do studies. One of the reasons we took up this study was basically to find out how people felt about Sjogren syndrome and what were the topics that they were interested in when they attended programs and events. And one of the reasons we've taken up GI issues today is because that was the demand which came from patients. Now, let me just start the presentation with sharing the slides. If you take a look at this slide, I think it tells you all. There are multiple perceptions about Sjogren syndrome, and that is what makes it such a complex disease. When doctors are asked to talk about Sjogren syndrome, the words they use are the one that you can see there: complex, systemic, autoimmune, chronic, things like that. When patients are asked about Sjogren syndrome, they're more concerned about the way the disease affects them, how there is a loss of confidence, how there is dryness, pain, feeling lonely, feeling tired all the time, being angry, feeling guilty about being ill, and so many other things. And if you ask society, even family members do not really understand this disease, which they cannot see. And that is really the vein of Sjogren syndrome. People label patients as being weak, as being lazy, as being shirkers, good for nothings. And this is what causes a lot of emotional burden in addition to the physical burden that the patients face. So Sjogren syndrome is different to different people. And I think that is why it is so important to understand the patient's perspective about Sjogren syndrome. When we talk about patient's perspective, let me first talk about why it is so important to listen to patients. We greatly appreciate the efforts made by researchers and scientists and medical professions to help improve the quality of our life. But many times we also feel that people do not, or even doctors do not really understand all that we go through, the burden of disease that we bear. And we feel that patient reported symptoms are stronger indicators of quality of life as compared to systemic manifestations, as is said by some scientists in a study report which has come from it. Before I go to the next point, I just want to ask, are you seeing the entire slide on your screen? Or because I am kind of getting not an entire slide on my screen. Is that okay?
We can see it.
Full slide is visible.
Okay, fine. So the reason why patient's perspective is important is that very often the patient's experiences are trivialized by doctors, trivialized by families, and trivialized by society. A comparative study of patients with the other connective tissue diseases like rheumatoid arthritis, systemic sclerosis, lupus, and Sjogren's, which was undertaken, showed that Sjogren's showed the lowest vitality in social function. Sjogren's patients were found to have the lowest levels in vitality and social function, and the second lowest levels after systemic sclerosis. And yet, this remains one of the least prioritized diseases when it comes to talking about rheumatic diseases. Even though we are supposed to be almost ranking equally in prevalence to rheumatoid arthritis, that means there are a large number of patients. Very few get diagnosed, as all the doctors have told us before my talk, that it's difficult to diagnose and why they have explained to us very well. But the fact remains that because many patients do not get diagnosed, the burden of illness is never really calculated and never really understood. And a greater understanding of this of the complexities of Sjogren's can only happen if the experience of the patients and the knowledge of the doctors is both seen together. And therefore, it is all the more important to have dialogues like this where patients and doctors can talk to each other. Going back to the study, I don't want to dwell too much on the details, but these were the objectives. The methodology that we used was an online survey, and we had a virtual sharing session where about 25 participants from all over the world participated and shared their stories and views. We had in-depth interviews with individual patients. And Radhika here will share with us some of the learnings that she has had while doing these in-depth interviews. The limitations of the study, of course, are due to the fact that we are able to reach only those who had access to technology and were English and Hindi speaking. So we definitely need a much bigger and a greater study to say that this is the impact of on Sjogren syndrome patients, but this is an indicative study, if I may use that term. The study findings are now, we looked at, we got several responses, but finally, when we did the analysis, my colleague Daksha Bhatt has helped extensively with this along with Radhika. The analysis was based on 62 valid responses. 17 patients declined to answer questions on how Sjogren's impacted their lives. These were the questions which included personal questions about how there was an impact on their personal lives, relationships, and things like that. The gender profile of the study showed that there were 94% females to 6% male. In fact, after this also, we've been getting a lot of responses from male patients. So I'm beginning to think whether we really are going to have a ratio of more than 9:1 that we classically have, because a lot of male patients are registering as patients now. So maybe it is that they were not getting diagnosed early. So that's just an early thought. But yes, that seems to be more male patients registering for Sjogren's as Sjogren's patients. 29% of the respondents were between the age group of 20 to 40. Dr. Sandhya told us that most patients are between the age group of 30 to 40, which is already 10 years earlier than the European cohorts. But we are finding patients who are even in their 20s. And that is very striking, because their entire lives they have to deal with this disease. And I think we really need to start taking into consideration that Sjogren's is much more than a disease of dryness and does affect lives in many different ways. If we look at respondents by region, we will see that I think the charts are self-explanatory. We have people from all over India, with the largest cohort being from Western India. 42% have been living with Sjogren's for 10 plus years. Now, that should be an encouraging thing for the younger patients, those who have been newly diagnosed, that the myth that Sjogren's is life-threatening is not true. People can lead near normal lives, and we have amongst us half the population, which are what I would call veteran Sjogren's patients or champions. 16% of patients have been diagnosed with less than 2 years of diagnosis. So that means these are new patients, and these are the patients that we give a lot of attention to, because they need support in the initial years. Their families need to provide them with support in the initial years, and that's why this is, I think, one of the most important slides in the presentation. If you notice, the classical symptoms of sicca, fatigue, and joint pains have, of course, emerged as the most bothersome for most patients, with severity of dry mouth and dry eyes as being reported the highest. But it is also interesting to see that people have reported digestive issues as the next most bothersome symptom. Now, I would like Dr. Kurian to help us understand how many of these symptoms that we experience on a daily basis are actually serious, because it could be that these are non-serious symptoms, but the fact that they happen every single day and affect our lives is probably what bothers a lot of us on a daily basis. And therefore, I think we need a different parameter of looking at quality of life, because even if the symptoms are not serious or organ threatening or things like that, but some things which bother you on a daily basis can really erode the quality of life and the happiness of patients. And I think that is something that as a patient representative, I would like to point out to the doctors here. Mental health and gynecological issues have come up as also major things. Now, as a Sjogren's patient, I know that doctors are concerned about lung involvement, kidney involvement, heart involvement, neurological involvement, and these are more serious indicators. But as a patient, I realize that when we talk about mental health and gynecological issues, when we talk about UTI, these are something which affect our quality of life. And that is why my request to doctors is to also look at these when we are dealing with looking at the well-being of the Sjogren's patient. A lot of patients have coexisting conditions, and most of the ones that are mentioned here are very well recorded by the doctors. But it was interesting to see, and this is important for the patients to understand, that more than 20% patients do have rheumatoid arthritis, thyroid imbalance, and hypertension as coexisting conditions. In this cohort that we had, a lot of patients, I mean, very few patients showed the rest of the condition, but this is a very small cohort, so we cannot make any judgments based on this data, except for the fact that yes, rheumatoid arthritis and thyroid seem to be the most common coexisting conditions. This, I think, is one of our important findings, which we are happy to share with both the patients and the doctors. Like I said before, we believe that Sjogren's is a life-altering condition. Even if it is not a life-threatening condition, it is definitely a life-altering condition. And therefore, 91% of patients have had moderate to severe negative impact on their life due to Sjogren's. We can always argue saying that many other diseases have severe impact and Sjogren's impact is not that severe. But that is a matter of looking at it from a point of view of life-threatening ideas. I would like to look at it also from the point of view of daily living and the point of view of quality of life. So let us keep that in mind. 37% reported a negative impact on career. And as we find younger and younger patients getting affected by Sjogren's, we must realize that this number may even go up. So we need to look at that. Sjogren's affects families, as I said in the beginning also. 40% of patients said that their family relationships and social interactions were affected by Sjogren's. And this results in a huge emotional burden. Just to give an example of the kind of stories that we heard, I'll now request Radhika to just share a few stories of what she heard from Sjogren's patients. Radhika, over to you.
Yeah. So thanks, Kirtida. I'm going to take off from Kirtida and what she said that, literally Sjogren affects families. It's not just the member, but it's also the families which get impacted. And when we talk of, disabilities being invisible, what is so sad to note is that literally they are also invisible to their families. Almost out of, all the people that we spoke to, almost 50% talked about how their families had been extremely supportive. And that had really helped them to lead a good quality of life. But there was another 50% that spoke about the debilitating impact that families, relationships had on their lives. So just to cite, we had, I spoke to one senior teacher, she was an academician, and she spoke about, how she was prone to listening to insensitive comments by her family all the time. And, difficulties with accommodations at work. She says she's short and her husband is tall. So literally, the house is not friendly for her access. So the things are put away and stacked away, on top shelves, which she finds very, very difficult to access. And that itself is very stressful for her. I spoke to a young daughter whose mother is impacted with Sjogren's. And she spoke about, how her father was literally always telling her and her mother about how the mother was incapable. As it is, the patient is low on confidence. And further, these insensitive comments can really erode the confidence even further. And she also spoke about how the father did not even take them out for outings on holidays to mingle socially, and how that had an impact on the children who now find themselves incapable of making friends. And she says that even though my mother's condition, because of after years and years of listening to verbal discouragement, to stress, she now, reels through a lot of mental anxiety and depression. And, this is something that is so simple to correct, just simple words of encouragement from the family. Societally, I've had people who spoke about, as them being classified as not being suitable marriage material. And that is so disheartening if we overcome, if we meet these societal barriers. The last thing that we spoke about, Kirtida says that 37% talk about career changes. So while I did chance upon 2 patients who, had really gone through a difficult time trying to complete their education, there were more that I encountered who talked about career issues. And they said that, full-time working they found was difficult because of the common syndrome of fatigue. But even amongst them, I chanced upon, many members actually, who looked at alternative career paths which were physically less demanding. I spoke to an executive who worked at a ticketing agency, and she has moved on to become a full-time yoga facilitator who really inspires and helps people in their journeys. I have also spoken to a dentist who found it initially difficult to, to move careers, but later on she has now moved into becoming a successful content writer and blogger, and what a chic career to have as well. I have also spoken to a fashion consultant who continues to make waves. She has not changed her career paths, but she has understood that her condition requires certain accommodations, certain compromises at work that she would need to make. She has learned to accept her condition and to prioritize herself. So, these are some of the amazing journeys that I've, hit upon as I spoke to many people. And I think to me, I came up with the 5-point marker, which I feel is so important for, all of us, not just patients, but also us as a society to look at, awareness, much more. A lot of awareness needs to be generated amongst the community, amongst patients, and even in the far out areas, even amongst, the doctors, the medical community. Dietary changes and yoga, that's one thing very important for patients. Acceptance of their condition, that's another one. Prioritizing the self, and last but not the least, being positive. So with that, I'd hand it back to Kirtida.
Thank you, Radhika. So let's move on. I think your stories told us a lot more than the figures did. So impact of treatment, I think this is one slide which I love to tell all the new patients that there is hope. And when you get diagnosed initially, life is very difficult. And you do have to learn to manage your symptoms and learn to adjust to the medication and things like that. But with proper treatment, lifestyle changes, and a positive attitude, you can significantly improve the quality of your life over the years. And 84% people actually said that. So that is, I think, a wonderful way to realize that diagnosis and treatment is extremely important for us Sjogren's patients. I'd like to end with a few learnings and recommendations. I won't get into the basics, which is about how we need awareness and we need upgradation of skills and things like that. But I think I missed the slide anyway. So what I would like to focus really on here is, oops, I think I've messed up. I've gone back to, okay, anyway, let me just close the slides, it's okay. What I really wanted to say was we need to work together. I think doctors and patients need to work together. We need to think about ways to conquer Sjogren's together. There are many things that we need to do, probably like the countries in the Western world are already doing special treatment guidelines, which are focused with the taking into consideration the realities of that country. I think we could do that in India, because we're realizing that younger lot of patients are being getting affected, and therefore we need different ways to deal with Sjogren's, not only medically but also to support them socially and career-wise and all. I think one of the other important things that we've been currently working on as the rheumatic diseases patient group, the collective that we are forming, we need to find ways in which our rheumatic conditions can be treated under the as kind of disabilities under the RPWD Act, and if we could provide some kind of accommodations, especially for those who have chronic illnesses. See, at the moment we don't exist. We don't exist in the data of government records, whether it is non-communicable diseases or rheumatic diseases. In fact, it's very interesting that we even filed RTIs, and we tried to find out what provisions there were for rheumatic conditions, and there are none. They don't even have us on records. So is there a way that we can make the country more aware about people who suffer from rheumatic diseases? And now I'm talking about all rheumatic diseases, Sjogren's included. And if we could find a way in which we could have some kind of specific accommodations that people can get at their workplaces, which could be something like flexible hours or extra leave when they are sick or something like that, or a small timings which can be or working from home. I think that is something which COVID has now taught us. So if we could do some of those kind of things, and if doctors could support us in identifying that these really need to happen, I think that would help us a long way in going ahead. In conclusion, I'd just like to say that as we realized and as we heard from the doctors, that only a few percent of Sjogren's patients have very serious disease. But at the same time, a large number of patients have disease which affects them on a daily basis. And therefore, the burden of disease that they carry on a daily basis is very high. And therefore, the kind of understanding and support that they need is also very high. I think one of the things that most of us patients feel and feel very, very strongly about is that we remain invisible. We remain invisible to the family, we remain invisible to society, our plight remains invisible even to doctors. And that, I think, is one of the things that we need correction in. We need to be taken more seriously. Amongst the rheumatic conditions that generally get talked about, Sjogren's never finds a place. Whenever there's a seminar or workshop, everything else gets talked about, but Sjogren's never gets talked about. And what I sincerely feel as the voice of patients with Sjogren's is that if a little understanding, a little support, and a little sensitivity was given to us, a little importance in medical facilities and getting targeted treatment is given to us, we will be able to lead lives which are near normal. We would become a part of society. We would not kind of vanish and become invisible from society, but we could actually contribute to society. So we need very little from all of you. We need attention from the doctors and researchers. We need attention from the family and sensitivity from the family and society. We need little, but we need that little very, very much. So with that, I'd like to end and I hand over to the moderator. Thank you very much for listening to us. Thank you.
Thank you, Mrs. Kirtida and Mrs. Radhika, for this is exactly what is needed. You have done such a wonderful job, because what matters is what the patient feels, what the test results say, what the physical examination finds is less important than what the patient really feels. And I think you have rightly found out that many of our patients are having digestive issues, as you have described it, and we have found an expert, Dr. George Kurian sir, to talk about it. We all are not only Indians, everybody loves food. Who doesn't love food? And actually, if one cannot enjoy the food, it's difficult. You know, if you have a dry mouth, you have dry, thick saliva, you cannot swallow properly, your taste buds are gone. You know, it's a problem. Also, everything about the food and diet is not necessarily be the truth. Some are truth, some are not so much truth, some are totally untruth. Like, you know, we believe this food is good for that, that food is bad for this. It's not so simple as that, but there is some truth in it. Like, you know, we know that there are some dietary components which have some role in controlling inflammation. There are microbiota and gut flora which are being attributed to disease pathogenesis as well as control of disease. But this is not everything. This is one thing. But what the patient feels is important. So I now, without wasting time, I invite Dr. George Kurian sir, who has been patiently waiting and listening to all our rheumatological jargon. Thank you, sir, for being so patient. And you are the star today because your topic has been found as the most vital clinical or the patient observed problem. And so without wasting much time, I welcome you, sir, to deliver your talk on digestive issues in Sjogren syndrome.
Thank you, Debashish. I hope I'm heard. Am I? Okay. Now, can I have the slides, please? I'm very grateful for the education I got here about Sjogren, both the clinical and the patient-oriented research that has been done. Because this is not a disease that I learned in medical college. I'm also grateful for being exposed to the information inflow. Now, can I share my screen? Yes, thanks. That's beautiful. Now, I'm a retired gastroenterologist. I'm going to speak about gastrointestinal disease and Sjogren syndrome. This is a list of diseases that come with Sjogren's, and you can see that there are a category of not serious disease and serious disease. What I call serious disease is a disease for which we need to do something positive. The not serious disease is disease for which we don't really need to worry about. Now, high on the top of this is irritable bowel syndrome and functional bowel disorders. Now, I have been looking at the data that was given to me. Kirtida told us that 87% complain of gastrointestinal disease. But if you look at the lady who worked with, I'm sorry, I've forgotten her name, who they at Debashish's work, you see that there's only 3% who actually were referred to a gastroenterologist. That actually tells you that serious disease that required a gastroenterologist to see them was only 3%, while the large proportion of them did not require treatment with the gastroenterologist. And so I think this is what it represents. Next slide, how do I do it? Yeah. This is just for patients to understand the basic anatomy of the GI tract. This is your mouth, where you chew and your saliva comes in and moistens it. The food passes into this tube, and this is not important from a point of view of Sjogren's disease, except at the bottom there is a valve that prevents any food from going back into the esophagus. The stomach works like a mixing machine and churns the stuff into something that is like a very thick slurry. And that is poured into the small intestine, which is the red or the pink small intestine that I've shown you. Now, if you have big lumps there that cannot be digested, so in order to make it smaller, the bile in the liver, shown by the liver disease here, and liver in yellow here, sends in bile salts, which makes it smaller. And that allows the enzymes in the pancreas to pour in and digest carbohydrates, proteins, and lipids, and also to the intestine itself is full of mechanisms to break down small carbohydrates. Now, all this makes big, complex molecules into small chemicals which are easily absorbed. At the end of this, whatever is remaining passes into the large intestine, and here no major function occurs except the absorption of fluid. So what finally ends up in this area is hard stool, which is passed out. So formed stool is what happens normally. Now you can notice that these organs are involved with the GI tract, and they also perform their functions. Can I have the next slide? Is it with me? Yeah.
No.
So we have a lot of patients, as I said, who have mild diseases or non-serious disease. The majority of them, understandably, have irritable bowel syndrome or functional bowel disorder, which is what I will be speaking about in a small variety, a number of them have food that refluxes back because this valve doesn't work, and that is called reflux disease. And a large number have gastritis because it is found in, if you take a normal Indian and look inside his stomach, you'll find it often red. So that's asymptomatic gastritis is also one of the things that happen. Can I have the next slide, please? The serious disease, you heard about autoimmune, and you saw the man with the gun shooting the human body. But autoimmune disease is a reason for Sjogren's, and autoimmune disease also produces pancreatitis, disease of pancreas, and disease of the liver, and also ulcerations in the large intestine. So all this is part of the same thing. Ulcer disease is found in patients with Sjogren's as in normal people. But these three are found more in Sjogren's than in normal people. Celiac disease, which we will spend a little time on, has been reported widely in the north of India, but very little in the south. And we think it has to do with the fact that the genes of North India is related to Europe. The ancestral North Indian gene is related to Europe, while most of the ancestral South Indian gene is not. Next slide, yes. The symptoms of GI disease in Sjogren's: pain in the stomach, gas, bloating of the abdomen, loose motion, constipation, loss of appetite. Now we'll go through each of these and discuss them. Pain in the stomach can occur anywhere, and gas can occur. People talk of gas when they belch or they pass large amounts of flatus. Bloating of the abdomen, when a person feels the stomach is bloated, is really a symptom that has been overexpressed, and I will talk about it later. Loose motions are not often loose motions, but are frequent motions. Constipation is defined differently in India and elsewhere. In India, if a person doesn't have one bowel movement a day, he gets very upset. But there are various studies done in the West that even once in 5 days, and people are not upset. So it is a cultural factor as to what constipation means. A loss of appetite is something that affects anybody who is down and has a chronic illness. So can I have the next slide, please? Yeah. Now, the common causes of pain in the abdomen, the most common cause of pain is usually psychological. It's easy to understand this if you see a child. Children, if you take a class of children going to school, if the teacher announces that they'll have an exam the next day or they'll have a series of exams, many of them develop pain. But if the teacher tells them the next day that we're going to cancel exams for 3 months, all the pain disappears. The same thing happens with loose motions. I had an adult cousin who was going in for a simple surgery, but she said the whole day she was going to the toilet 2 or 3 times. So pain is most commonly due to psychological causes, but it's also due to ulcers, it's also due to gastritis, but importantly due to a disease of the pancreas called pancreatitis. Next slide. Next slide.
Yeah, just.
Okay, sorry, I don't know. Okay. So we're looking at pain in the abdomen. The psychological causes are irritable bowel and functional bowel disorder. The disease that cause pain are ulcers, gastritis, pancreatitis, obstruction of the intestine, not common in Sjogren's and elsewhere, and inflammation of the intestine, as occurs when you have ulcers anywhere in the intestine. Next slide, please. So how does a person, either a patient or a doctor, decide when he should investigate a disease? How does he say this pain is due to serious disease or it's psychological disease? When a patient has very severe pain, especially in a situation like pancreatitis, and often radiates or goes back to the back, then you say, hey, this is happening. When the pain is episodic, that means it comes and goes, then it's a serious disease. If you have pain that arouses a patient from sleep, a classic example, when I had pain waking me 2 nights in succession at 2 a.m. in the night, I knew I needed to have an endoscopy. And sure enough, I had an ulcer in my small intestine. When pain is associated with severe vomiting or uncontrollable diarrhea, or the stomach is visibly bloated, then that's serious disease. On the other hand, psychological disease is relatively mild pain, and it only occurs during waking hours. Next slide. When people talk about gas, which is belching or passing of wind, gas is actually not a sign of serious disease at all. The most common symptom where you get gas is when you have irritable bowel syndrome or functional bowel disorders. And these are psychogenic or diseases that occur under stress. The other situation is we talked about reflux of stomach contents into the esophagus. When the fluid content occupies the esophagus, the gas has to be displaced and will come out as belching. But otherwise, gas by itself is belching, and passing of wind is not an indication of serious disease. Next slide. Yes. Bloating of the abdomen. There are serious disease when there is bloating of the abdomen with severe pain. Sometimes the bloating of the abdomen is due to water and can be easily picked up by using an ultrasound. The psychological component, when many people complain, my abdomen is bloated, as happens, no, just go back, please. Happens very often in irritable bowel syndrome and functional bowel disorders. Now, there's a reason for this. They found that they have by experiment shown that people who have a feeling of bloating, a feeling of fullness, a feeling of gas, have the same amount of gas as people who don't. So people who don't say that suffer from gas have the same amount of gas in their intestine as people who suffer from it. So what is the explanation? The explanation is that the people who complain of gas, even with a small amount of gas, their bowel feels it. That means they have a hypersensitive bowel. This is like when a mosquito bite occurs, some people feel very upset by the mosquito bite and react and rub their palm, but some people hardly notice it. So there are people who react to small volumes of gas because the bowel is hypersensitive. And again, this is psychogenic. So the psychological pressures of life make some people sensitive to small volumes of gas and small volumes of feces. So that's why it's called a hypersensitive bowel syndrome. Next slide, please. People talk about, I'm having plenty of loose motions in irritable bowel. The loose motions are not loose motions due to water. It's because a colleague of mine and I did a study on the stools and found that the stools of people who had the loose motions and didn't have the stool motions had the same amount of water. But if you find that there are loose motions, it could be due to serious disease, but rarely that. When you have inflammatory bowel disease, cancer of the bowel, or something called celiac disease, about which I will spend a little more time later. Next slide, please. What indicates serious disease? If a disease is serious, you will find the person passing stools both day and night. Often if there is blood in the stools, it is serious disease. If there is a weight loss of more than 5 kg rapidly, then it's serious. If the stools occur only when a person is awake, he gets up in the morning, he passes stools. He goes for breakfast, passes stools. Or he goes again for another meal, he passes stools. These are indicators that it's psychological disease. When a person has sleep problems, I usually ask 3 questions about this. One is, do you sleep well at night? When you wake up, do you feel fresh? And the third question I ask is, do you ever have disturbing dreams? I remember one patient who told me, yes, I have these dreams of going in an aircraft and being pushed out of the aircraft. He had no reason for that, but these are the sort of dreams that he had. And if there's no significant weight loss, it's more likely to be psychological disease. Next slide, please. Constipation is always a cause for worry. The serious disease is when there's cancer in the last part of the large intestine. Constipation is often a reason. Psychological disease, irritable bowel syndrome produces constipation. Now, this isn't, as I said, this is a cultural defect. When we don't have one bowel movement satisfying us in the morning, we have we call it constipation. But in many cultures, a person may not move stools every day, and yet they don't consider it constipation. When it is difficult to pass stools, that can also be constipation. Next slide. So when is constipation to be investigated? When it's associated with iron deficiency anemia, when there's a family history of colon cancer, when there is a loss of weight, when there's blood in stools, or finally, and I think this is important, if a patient requests investigation, then it's important to investigate it. I do not investigate irritable bowel syndrome because the more investigations you do, it adds a feeling of illness. So I usually add isabgol, which is a good source of fiber. In fact, we've done a trial with isabgol and found that it actually improves a sensation of emptying in Indian patients as against a dummy that looked like isabgol. So using isabgol is a good way of treating irritable bowel. And my usual dose is not just a little isabgol, but 2 tablespoons of isabgol thrice a day. We also recommend people to increase fiber in diet, which means increasing the intake of fruit and raw vegetables. Next slide, please. So when you come to it, what do you think are the minimum tests to be done in a patient who has GI problems? Do a complete blood count and a blood picture. If that is normal, you're dealing in Sjogren's, you're dealing quite well without any severe disease. Do a liver profile, because liver disease is often not associated with very obvious symptoms. And you can progress to a very late stage of liver disease before you pick it up. So I always ask people to do a liver profile and a complete blood count. This is besides the tests that we were told that Sjogren's patients should have. In addition, the liver profile tells you whether the patient is losing albumin in the bowel, and that will show you a lower level albumin, not normal. So these are the indications that tell you you're dealing with a severe disease or you're dealing with a mild disease. In most cases, of course, it's a mild disease. Can we have the next slide? Yeah. When you have specific tests, when I said ulcers, they need to do the specific test with an upper GI endoscopy. When you have hepatitis and the liver tests are abnormal, please do a liver profile and an ultrasound. Exclude other causes of liver disease, common liver disease like hepatitis B and C. And pancreatitis, we look for the serum amylase lipase, a CT scan, and autoantibodies. For inflammatory bowel disease, we have to do colonoscopies and multiple biopsies at different levels. Now, celiac disease, as I said, is a disease that's reported widely in the north, but not so much in the south. So if someone tells you, some doctor tells you that you have celiac disease, there should be a confirmatory diagnosis made by biopsy of the small intestine. That I think is the last yes. Now, I would take up some questions that were asked. So as I said, there is a large number of patients who have non-serious disease and a small number of patients who have very severe disease. And I think the reflection that we saw, 87% have GI problems, but only 3% in Dr. Dabash's series were actually referred to the gastroenterologist. some questions that were raised. The first is, many patients are put on gluten. That's because celiac disease is seen as an allergic response to, many patients are told not to eat gluten, which is something in wheat, which means they have to change their diet completely. I mean, just imagine a person who's used to rotis and naans, etc., having to stop that and switch over to a rice-based diet. Now, this is based, often people do this without actually doing the test. If a person has to be put on a gluten-free diet, which is quite difficult for many people, it should be accompanied. It should be accompanied by a biopsy and a test called IgA tissue transglutaminase. Because a biopsy is often, in the Indian situation, is often abnormal because of what's called tropical entropy. So I recommend that unless these two tests are normal, are done and found to be abnormal, gluten should not be restricted. The second issue is one of lactose. Now, many people in South India especially have lactose intolerance. I myself we did this on a study using a urine test. I myself suffer from lactose intolerance, but it hardly makes any difference if I drink lactose. One way to do this is do what are called provocative tests. You stop milk for a week, take only curd, it has the same proteins, and see whether you feel bloated. Stop it, see whether you feel better. Start taking 3 glasses of milk a day and see whether it makes a change. If it doesn't, you don't need to stop lactose. Now, there was a question popped up, and people asked me, any diet restrictions? As far as the GI tract is concerned, unless you have proven celiac disease by biopsy and tissue transglutaminase, or proven lactose insufficiency, please continue taking as normal a diet as possible, a healthy, balanced diet, as anybody would. One of you talked about how you were found to have cryptosporidia in your stool. Now, this often happens when you go repeatedly. A person with irritable bowel goes to a doctor, he repeatedly tests his stool, and then he finds, yes, there's a cryptosporidia oocyst. We've done studies on ordinary people in villages, and we found that 40% of them who are asymptomatic have cryptosporidia. So it's just finding a parasite is not sufficient to start treating or blaming your symptoms on that. In fact, if a person has cryptosporidia and you want to confirm it, you need to go into his colon and look for ulcers that cryptosporidia causes. If they're not there, then it's not a pathogenic disease. A third person talked extensively about bloating. And as I said, bloating is only a sensation, and that's because your bowel is hypersensitive to small volumes. Because you have your intestine gets a small volume of gas, it tells your mind it feels bloated, but there's nothing absolutely wrong with it. It's more that the mind is making the bowel sensitive, just like some people are more sensitive to sunlight and some people are more sensitive to mosquito bites. Similarly, when you feel the urge to defecate, it's because a small volume of stool makes you want to go to the stool. So both bloating and frequent stools that don't raise you up at night can be overlooked. Now, a third person said, I have IBS, irritable bowel syndrome, and I was prescribed Pantocid. Pantocid is a very good drug, but it's used only for ulcers, not for IBS. Another person said, I don't want to take steroids because I was told that steroids produce ulcers. Be reassured, there is steroids do not produce ulcers. If your doctor, your rheumatologist says you've got to take steroids, go ahead and take it. Another person takes aloe vera. Now, I have no problem with aloe vera, which is virgin, taken straight from the plant. But I do have a problem with aloe vera, which is marketed through a company. They may have additives which do not suit you. Now, one of the patients said that I was finally found to have a condition called microcolitis. Firstly, when you go repeatedly to a doctor and then he says, okay, we'll do a colonoscopy and biopsies, he finds it's normal, he may have sent the note to the pathologist saying, is this microcolitis? Now, if microcolitis is not seen by a specialist pathologist, it's often misinterpreted. Why do I say this? Because if you're going by European texts, their colonic mucosa and our colonic mucosa is different. And we will not, we in the tropical countries tend to have what would pass off as abnormal colonic mucosa in the West. So if you have a diagnosis of microcolitis, there are two things that you must do. You must ask for a second opinion or send the slide to a pathologist in specialist labs, and also do a test called fecal calprotectin. This tells you a whole heap of drugs. It tells you that there is an inflammatory condition in the colon. So don't accept a diagnosis of microcolitis, firstly, because it's very rare, and secondly, because the diagnosis needs to be made by a very good pathologist. So what is the advice that I would like to leave with you is, unless there is excellent evidence of disease for your GI problem, unless your liver function tests are abnormal, unless your pancreas tests are normal, and your symptoms are reasonably surely normal, don't restrict your diet. Eat a normal diet. Live life as normally as possible. Especially about avoiding wheat and lactose. Only be certain, unless a good test has been done, please take a normal diet. Please live life as normally as possible. Accept your GI symptoms. Accepting Sjogren's is also part of it, but accept your GI symptoms and say, I'm not going to worry about it. Many of these patients with irritable bowel have to tackle stress. And the stress is in things like, will I have a conflict in my family? I'm not talking to my brother because we quarreled over property. I'm worried about my disease. Will my children get it? Will this disease cause me to live a short life? All these ideas you can clarify by talking to a qualified rheumatologist who will tell you that your life is going to be the same and as long as anybody else, that the problems they will explain to you. But the psychotherapist was also there to handle the problems that you have, which are related to the disease. With this disease, will my brother take away my property? Will he fool me? All those sort of things will be handled by a psychotherapist. So I think the more major lessons I'd like to leave are the large majority of intestinal symptoms, gas, bloating, frequent stools, are very minor and do not indicate seriousness. The small proportion of patients have very serious disease and is often found frequently by the severity of manifestation. If you've got severe pain, if you've got diarrhea that wakes you up at night, pain that wakes you up at night, then they should be investigated. And if you keep worrying about frequent stools and someone does a colonoscopy and calls it a disease called microcolitis or ulcerative colitis, I think that needs to be emphasized. It needs to be treated. Okay. Collagenous colitis. Okay. I got a question right now asking if collagenous colitis is the same as microcolitis. Microcolitis has two things. In one, you find a lot of inflammatory cells. In the other, you find collagen lining the epithelium. So they're both part of the same family, but it's not very often that you find it. Yes. How to deal with motility naturally. Okay, if my usual technique for this is it's really one thing. First is attend to your own stresses in your life. Either you will need to heal relationships with others. A classic example is of a family where people are not friendly with each other. Families are breaking down. The second is to handle your disease and say, yes, I have this, but it's not a serious disease. And to live life as normally as possible. Many people say, no, I don't want to take that. I don't want to take that because it will cause me to have problems. That is not needed at all. The third is, and this I find difficult to talk to, is actually improve your spiritual life. I had a patient who used to say, who came to me with this, and I've talked to him and said, how many times do you say namaz? He says 5 times. I said, when you say namaz, which is a beautiful prayer, do you think of the words or are you thinking? He says, no, I'm thinking of my business, my loss in this business, loss in that. So I said, start thinking of the prayer. 3 months later, he says, you don't know how that helped. So these are the things that you can do to help yourself. Exercise and going out for activities that you think you cannot do are the best way to cure yourself about psychological stress. If you're worried about bowel movements, if I go there, I will need to use it. Learn to tackle that. I have a friend who goes on long journeys, exploratory journeys, with irritable bowel syndrome. He says, Oh, when I go on these journeys, I hardly feel like going to the toilet. But once it happened, so I went in, like the villagers, I went into the bushes and had a bowel movement there. So try and live life as practically as normal when you know that you don't have anything. Sorry, I'm trying to get these questions out.
Hello, sir. We are really running behind schedule.
Okay, fine. If they want any further answers, can I? How can I answer them? Because they seem to be.
I will provide people with their answers. We will answer many of the questions later.
Yes.
Like we have a lot of questions which have come up. We have noted down all the questions, and with your permission, we will take all of them up later and give individual their answers.
Sure.
I'm very sorry, but we are running a lot behind schedule, and we will need
That's fine. That's fine.
Wind up. And can I think I must thank you very much for allaying a lot of our fears that our disease, as we call it, gastritis and constipation and all, are actually not serious. And we need to, like, along with all other problems like fatigue and so many other things that we deal with, we have to learn with this also. And may I now request Dr. Danda to take the program ahead. Considering that we really have very little time, I leave it to you to proceed how we should do the next session, or should we just skip it, or how would you like to proceed?
I would like to, I mean, I have no problem. I have kept my evening free. And the idea is to have a dialogue in a very simple language. As Dr. George Quinn has, have you seen how simple language, in a very layman language, very slowly and clearly he explained. And after all, what are we chasing in life? We don't have to be, I am not so much worried about the schedule. So I would be very happy if Sapan continues. And if anybody wants to have their food and drink, you can always off your video and I can have it, or even on video, no problem. So I'll now invite Sapan to talk on. Dr. Sapan is very popular. He's known to all of you. Dr. Sapan Pandya is going to speak on the most important part which deals with the treatment and what are the strategies for conquering Sjogren syndrome in India. And after that, we'll have a very quick 1 or 2 point take-home message by each of the panelists, and then we'll close it. Is that okay?
Yeah. I'll also be fast in my. I thought I was going to speak more about what are the strategies for the treatment part has been taken over by Sunday already. So, how can I? Will you be sharing my slides, or shall I do it from here?
I can share it, Doctor. Just a minute. Sorry, I missed.
Fine. So I think that was a very, as Dr. Danda said, one of the most simplistic talks that I've heard, but so detailed and with the concepts that we need in gastroenterology. Somehow I've always found the Vellore faculty to be some of the best, the most engaging ones. You know, even when I was there last year, they managed to put down everything so simply. That's the best part. So anyway, I'll move on with my talk and try to finish it in 5 minutes so that we have at least 5 minutes to save. There's nothing much to say here. I think all of us already know. So this is the first slide of what we can do to conquer is divided into 3 parts. What can the providers like us, I'll start with ourselves. What does the medical fraternity, rheumatologists and the others who are involved in treating patients do? The second part is what can patients do, or you can do as an individual and as a support group, because that is those, you are the biggest, you're the largest stakeholders in this. And then what can health authorities, what can we prompt them or sort of lobby with them to do? These are the strategies by which we could actually not conquer but palliate and improve lives of patients of Sjogren syndrome. Can I move to the next slide? Yeah. So the first thing is about what we could do as healthcare providers, and we have been doing it for some time now, all of us in our own ways. Increase awareness by holding CMEs and those things. And as I told you, that I'm glad to say that when I started my practice, and I'm sure it must be sort of worse with Dr. Danda when he started his clinic in Vellore. We used to see patients who had not diagnosed for 8 to 10 years with Sjogren's, and now, as I said, it comes pretty early. About 2 to 3 years will be the average time when you are diagnosing Sjogren's syndrome. So while people are already aware, it is important to make them more aware. So Sjogren's syndrome should be included, and the best way to do it is having sort of case say vignettes which are most interesting for most of the crowds. So you could introduce, it is for up to us. We have been trying in our own way. The Indian Rheumatology Association has been trying at undergraduate level to either hold workshops in immunology, because all of this basically goes into immunology. With the medics as well as paramedic level, we will need to introduce that, so that even, as you well know, that in international communities, even nurse practitioners are aware of these things. They are able to diagnose. The doctor is just supposed to do the formalities. At postgraduate level, we could the Indian Rheumatology Association already sponsors sort of MD thesis, which can be they apply to us and we actually fund them. So we could have at least one thesis in every medical college, for example, on rheumatology, and some of them can be on Sjogren syndrome. Since it's a multi-system nature, most of the postgraduate level MD students find it very interesting. These cases, our cases are some of the most interesting ones when you have sort of multi specialty presentations. And then at the postdoctorate level, which is at the DM level or the PhD level, of course, we have research and we have dedicated Sjogren's experts, centers which are working on Sjogren's. Now we have investigators also like Dr. Sandhya, who has been working on Sjogren's for quite some time. So she could mentor students, get to the mentors, and there is a dire need for epidemiological studies, which are, I know, difficult to do, but somewhere we'll have to start to look at. For example, Dr. Danda, because of his data, could say that he feels that at least 0.5% of the population might be suffering from Sjogren's, and Sjogren's is believed to be, if not the commonest, even more than rheumatoid, certainly the second commonest disease now. We could have a special interest group on Sjogren's syndrome, and I must say here that Dr. Danda, under his presidency, when he was the president 4 years back, he started these special interest groups in a big way. He was also the pioneer of the patient education programs. Before that, we saw in bits and pieces like the one we held in Ahmedabad, which Kirtidaben knows. But on a national scale, for the first time, we had it only when we went to Vellore. And Dr. Danda really managed to have a lot of funds for us also. And we still have those funds, and we are still doing those CMEs. Because of COVID, we were a little delayed. So we could have a special interest group on Sjogren, which you already have. And Dr. Sandhya is one of the pioneers of that group. And we could have an annual meet on Sjogren, just where he had the international symposium, where I think Kirtida was with me once in France. They have this international Sjogren symposium, so we could have an annual meet on at least one day along with patients, or maybe 2 days. And as Dr. Danda again suggested yesterday informally, a newsletter sort of where patients could actually come out with a newsletter where you feel you can write things, stories such as the ones which are conveyed by Radhika, or even questions, queries, surveys, and those kind of things. Next slide, please. Can I have the next slide? Yeah, and what can can we do is have data banks. What can the providers do? So we can have data banks where we have registries. As you can see here, this is an example. I was just going through the UK registry, and I found that these are the centers, hospitals where they're already having registries. We badly need a registry of our own of Sjogren's syndrome, of what is happening in India, at least a chart, a data sheet of all the patients. So, and we need to define short and long-term goals, especially outcomes of what is happening to these patients. We have a lot of cross-sectional data, which means that what is the average age, median age, or the mean age of the patients present to clinics? What is their duration of illness before they come to us? What treatment are they on at that cross-section? But what we really need is the outcome. What is happening to these patients at the end of 5 or 10 years? How many of them are dying? How many of them are going into lymphomas? How many of them are, as Kirtida came with that data of 49% were leading good quality of life. So those are kind of things that we need to define. We need to validate the outcome measures in Indian context, the ESDI and ESPRI, which is basically from Europe. Maybe we should have an Indian hack like we have in rheumatoid arthritis, where we have changed some of the questions. One of our colleagues, Dr. Chopra from Pune, has actually validated that. So these are things that we as providers and as a rheumatology community need to do. Lobby with the government and insurance companies. Again, I must state that Dr. Danda had come out with these various cells in the Indian rheumatology, where we had a communication cell, we had an advocacy cell, patient advocacy cell, and we are working on that. So, but we will need as Dr. Danda has always said, and I now feel that he is absolutely right, is that the government listens to patients more than to doctors, and rightly so, because you are the ones suffering. So we need to lobby with the government, with the insurance companies, to see that they include that in insurance in some way. With the industries, we can lobby, and doctors can help you there to cut down on the costs of the pharmaceutical drugs that are coming. With the labs, also, that is what support groups do the world over. The availability of tests have to be more in more centers. Right now, they are only restricted to a few centers, especially tests like ANA profile or what is called the ANA blot. But we could have, since it's now done in a line immunoassay, we could have it elsewhere also. And then I was going to the website of the Sjogren's India, and all of you, I request, should go, all the doctors, that it's a good website, well maintained. So we need to update that website regularly, make it more engaging. And just as we have a patient section in the Indian Rheumatology Association, we could also have a doctor section in the website where doctors can provide stuff in the website, and we could have apps wherein patients can themselves put in information of their disease, and so that way we could gather data. Can have the most important thing that it's just not just the doctors, but even the patients who can themselves spread awareness amongst their own colleagues. It is very important not to scare everyone with these manifestations, because as I said earlier and repeatedly, we've discussed that Dr. Kurian came out beautifully saying that serious is just very few, about 5 to 6%. But we have to report these symptoms. Can you go to the slide number 5, please?
Yeah, just 1 minute. I
Yeah.
seem to be stuck.
No problem.
I will just stop the share and restart. I'm so sorry. It's just
that's fine. I think the rest of the things are that we need to bring in media, because that is something which and both kinds of media, print media as well as social networking sites. The fifth slide, the previous one, please. Yeah. Share and spread scientific temperament, most important. And this is something that I told when once the health minister was in Ahmedabad, the health minister of that time, I think Dr. Nadda, and we were in a meeting where he had called a group of doctors from sort of Gujarat. And I told him that, sir, this is one need, that we need to spread scientific temperament, because a lot of wrong notions are there, and as Dr. Randa was saying, and as family members, I've been trying to do that in my family. But the more we do and spread scientific temperament amongst people, that everything has to be based on evidence, most of it, then I think and understand it in a more scientific way, that will help a lot. Join support groups as this one, lobby with international groups as well, because they have Sjogren's Foundation in the USA, which is such a professional one. As I was saying, media, both social networking and print media. We will need funds for this, so we have to together gather funds in some way so that these can be, but funds are usually not a problem, and the problem in our country is using those funds. And I must say again that Dr. Nanda has managed to give us a lot of funds for doing patient, and we have done those in Ahmedabad also. We are trying to do that. I think we've done almost 20-25 physical meets all over India, but then we got stuck with COVID. So then we did a lot of online meets. So overall, we've done about 50-55 meets last 1 year itself, and we are still doing those. And very importantly, contribute to research. See, each patient has to know that while they are maybe unlucky to have the disease, they're also unique in having that disease. And so they could contribute to research by either giving in their clinical data, giving their blood samples, their DNAs, because unless we look at that and store that, we are never going to know what is happening truly in a scientific way. Surveys, just as the one that Kirtida just showed, are very simple to do, and I'm sure that we should be doing them more often to know what's happening to these patients. And very importantly, being a part of the guidelines. As you know that there are international guidelines and recommendations on Sjogren's syndrome. I don't think we have an Indian guideline. We should come out with that. The Indian Rheumatology Association, the state chapters also have to come out with those things. And as you know that now patient leaders have become an essential part of the team that decides on these guidelines and recommendations, because it is the patients who are suffering. So they know what is best happening to them. So some of you could actually get into those guidelines as patient leaders, and we should come out with that as well. Next, please. Yeah, so as I said, what can health authorities do, organizations do? The Indian Rheumatology Association, I told you much about that, and Dr. Danda has really done a lot of work and helped us bring out those things. We also have a lot of state chapters, as Kirtida was referring to. We have the Rheumatology Institute in Gujarat, like that. We have a number of state chapters who are doing their bit to increase awareness. We have the Indian Rheumatology Association National Conference, where we are now graduating to the level when we have parallel patient support group meets. So those are again very important, and we would be having them in the future as well. This year, of course, it's going to be a virtual event, but from next year, we are hoping that it's going to be a physical event. Updated guidelines, recommendations by the special interest group, representatives to the lobby with the government. We discussed that, including insurance, medical education. Again, the important thing, the problem is that in the post-graduation curriculum, since it's mostly neurology and cardiology, which takes up most of the weightage in the medical colleges, we need to bring in rheumatology in some way. And that is something that the Indian Rheumatology Association has been trying. Because when you go to sit down in practice, or you go to a government OPD, or you go to a hospital, you can get all kind of cases, not just neurology and cardiology and gastroenterology. So that is something that we need to do. Very importantly, fund research, clinical trials, they'll all need funds. And so for that, I think all of us have to lobby together. So this is just a sort of a nutshell what all of us can do and need to do to bring about, to try and, if not conquer, at least ease the lives of our patients and give them a better quality of life. This will be over decades, of course. Each of this, of course, has to be done with a deadline. So with that, I think I would now welcome any kind of views or any questions people have, any suggestions. And as the secretary of the Indian Rheumatology Association at the moment, I can assure you of any suggestion that you have, that we'll try and follow that. And of course, Dr. Danda is the Asia Pacific head, and his experience always counts. Always helps us also. So together we will try, and Dr. Sandhya, of course, is the lead for Sjogren syndrome in India. So all three of us will take your suggestions if there are any. Thank you.
Thank you, Sapan, for such a brief and sweet talk on how to take things forward. Before I invite Mr. Roy and Ms. Oja for the next question answer session, etc., I would invite each of the panelists, Dr. Sandhya, then Dr. George Kurian sir, and Dr. Sapan, to give just one sentence take-home message for each. I will say also at the end of it. Dr. Sandhya, are you there? Sandhya? Can you start with Dr. George Kurian, sir? So you have to unmute, sir.
Sir, can you please unmute?
Yes.
Dr. Kurian,
Yeah, I've done that. Okay. One message, one sentence. Okay. Gastrointestinal diseases have lots of symptoms in Sjogren syndrome, but only a small number have serious disease. How's that?
It is as sweet as it can be, sir. Thank you, sir. Sapan, before Sandhya comes.
Yeah, no, I think I said that. The most important thing I feel is trying to spread the scientific word and scientific temperament amongst all of us. If we have that, I think all diseases will be easy to marshal. Thank you.
Okay. Before Sandhya comes, I think she seems to be offline, or I don't know, she may be away from the computer. I would just like to say one, put words into your mouth by what you have said. Mrs. Kirtida's study had shown, you said very nicely that Sjogren's is not a life-threatening disease, but it's a life-affecting disease. So that's a very important point you said. So Sjogren's will not, very unlikely, it will kill you and cut short your life significantly, unless very rarely someone gets lymphoma. Even that is curable now. So that is one. Number two, I'll take from Dr. George Kurian's word is very important, that you try to be stress-free and relaxed. I would like to unify something what all the three have said is, if you notice Dr. George Kurian talk, there was one thing he said. He asked his questions, asked these three questions to the IBS patient. Did you sleep well last night? Did you get up in the morning fresh after sleep? And third thing is, did you have a bad dream? Very important, because what is this IBS or predominant GI symptoms in Sjogren's is part of a constellation of similar diseases or overlapping circles of irritable bowel syndrome. What Sandhya said, fibromyalgia, widespread aches and pains and fatigue. There are premenstrual tension, and there are many other migraine, sometimes tension headache. All these are called central sensitization disorder. And these are because of imbalance in the neurotransmitters in the brain, that is the endogenous opioids. You know, the brain produces normally opium-like substances, which relaxes us. On the other hand, we have substance P, which can produce pain. What happens in patients with chronic widespread pain like this? You have more of substance P, which causes more pain, and less of serotonin and endogenous opioids, which give sleep and makes us relaxed. So this imbalance is lost, and these three questions are very relevant because people who have a disturbed sleep or who have got a sleep full of dreams, you get two kinds of sleeps. We get something called REM sleep, or rapid eye movement sleep. Other is called slow wave sleep, or a restful sleep. Most people have a balance, and the early night we have a REM sleep, and later in the night we get slow wave sleep. And slow wave sleep is the one which gives you restfulness. But if you have a REM sleep, or full of dreams throughout the night, then you are like a wakeful state, even though you are sleeping. So your muscles are acting, you are not getting any rest. And this is one of the mechanisms. Dr. George Kurian sir would know there's so many neurochemicals in our brain are linked to IBS, and these are all closely related. So why I'm saying this is these are absolutely doable things by keeping yourself stress-free. But it's not easy. How do you keep yourself stress-free? Dr. George Kurian sir said one more thing, that do exercise and keep yourself physically active. Go for walking, running, jogging, or etc. And one of the things in chronic pain syndrome of fibromyalgia is to do aerobics, and something like, you know, in fibromyalgia, people recommend Zumba dance and that kind of activities with your family members. And that not only reactivates your deconditioned muscles, that also eventually gives you restful sleep and relaxes yourself, reduces your substance P, and enhances more of serotonin, enhances more of the endogenous opioids, and serotonin gives you sleep. So this is very important. And the last thing I would like to say about everything, about overall things. There have been so many questions about, do I do this? Do I not do this? Do I do this? Please don't chase after too many deadlines. This is a Western culture of deadlines, which gives you stress and nothing else. Don't think people with a lot of deadlines, meeting the deadlines, they are very successful people. They only add to their stress and raise their blood pressure, and eventually it doesn't really pay well. So I would like to say three things in life. Yes, be spiritual, very spiritual as you like to be, whichever way you like, but don't be superstitious, don't be too ritualistic. That is one. Number two, never forget logic and rationalism. If you have some ideas and thoughts, this may be good for me, this may be bad for me, all of you are educated. Please apply your logical mind. We often forget that logical mind, and when you are stressed, we become more illogical, and anybody says do this, do that, and you will do that. So I think never forget that the logic and science, you don't have to be a science graduate to be scientific. You can be an arts graduate or a commerce graduate. You can be still logical and scientific. And once you do things in a logical way, you are less likely to be victim of a lot of unnecessary vicious trap of negativism and stress. And third thing is equity. So I believe in science, logic, and equity. And that is very important. There should not be a first-class type of treatment for some people and a second-class type of treatment for some people. So I think you as a society can encourage what Sapan said, by your group, Sjogren's India, should act by lobbying with the government, the policymakers, the insurance companies, the pharma industry, and various other things by your activities you can do. You know, Swedish Rheumatism Society is the biggest funder of medical research in rheumatology in Sweden, not the government. So, and Swedish Rheumatism Society is a patient group who have prevented the government from stopping inpatient admissions for rheumatology. There was a proposal by some politicians in Sweden that rheumatology patients are all outpatient, they don't need admission. So take away all their beds. It is the patients group, Swedish Rheumatism Society group, who compelled the government to stop this and withdraw this bill. So the patient power is very important. Empowering the patient is very important. I'm very grateful to all of you, in fact, for doing this study and expressing in your language. We have always a communication gap. Many a times doctors don't understand patient's language, patient don't understand doctor's language. It's not the language, the semantic itself. It is just the way we talk in a different way of understanding things. Like, as I said, a fibromyalgia, Sjogren syndrome patient rarely comes to a doctor telling, doctor, I've got dry eye and dry mouth, so you diagnose me as Sjogren syndrome. Nobody comes like that. He will be coming with telltale features of Sjogren syndrome for 10 years. Someone putting eye drop for 10 years. If you ask them, do you have dry eye? He might not even say he's got dry eye. But if you say that, do you have grittiness or sandy feeling in the eye? Do you put eye drops in the eye? Or instead of dry mouth, he will say, yeah, do you have loss of teeth or your premature loss of teeth? You look for it. Patient would have forgotten 10 years back at the age of 30, he lost all the teeth and nobody bothered to ask about it. So it is that communication gap between doctors and patients we have to strengthen first, and the patient groups can really take things forward. And I think in India, we have just initiated that activity and it cannot be successful. The patient activism cannot be successful unless we have dialogues like this ongoing. So thank you, Mrs. Kirtida, and all the team members for such a wonderful opportunity for all of us to learn. I must say we have come to learn from you today more than we came to teach you. Thank you very much. Thank you, Sapan, Sandhya. Sandhya, are you there? Dr. Sandhya?
No,
okay, if
I
she's
don't
not
think
there. Okay, so I will now hand over to Mrs. Kirtida. Thank you very much.
Thank you very much, Dr. Danda, and all the doctors who have been here with us. Now, with the privilege that I have of having organized this, I think I'm going to take the decision that unfortunately, we have no time to take live questions at the moment. We have received a lot of questions, but I assure you that we will answer them individually on by message or chat with you. Fortunately, a lot of the questions have already been answered by Dr. Sandhya on the chat. I have a whole set of questions which have been collected. As a patient educator and leader myself, we have been dealing with a lot of these questions even during our regular meetings and interactions. Maybe we will have a special session to just answer a lot of these questions. But unfortunately, it is really half an hour beyond the schedule. And of course, I'll give Dr. Sapan a chance to say what he has to say for a minute. I won't close before that.
I was just saying that you could email to us and we will still answer those questions.
Exactly. That was what I had in mind, that whatever questions needed consultation by the doctors, we will do that. Just bear with us. We have not been able to take live questions today, but I think it is not fair to make everybody still wait, because people are patient and the doctors have given us more than adequate time. And I think I must thank everyone for their time. The audience and the doctors are here with us, and that has been the success of the program. I wouldn't have been able to do this event unless the team which helped this event to get through was there. So I thank Mr. Roy and all the team members who have been here with us. I would especially like to thank Radhika and Daksha, who have stood by me for several days trying to put this this study together. Neetu Wadhwa, despite her ill health, has helped with the technical support. And this is what I mean when we say that patient group leaders help each other and support each other. So that has been very important. The family has always stood by me, and that has been one of the reasons why I have been able to work for Sjogren's India for so long. I think it's very important that all of us continue to work together. One of my last requests to patients is that please, let's come together, let's raise our voice, let's talk about our stories. There is a lot of reason why doctors cannot talk about us because they are bound by patient privilege. But if we talk about our own lives, I think we have the privilege to talk about ourselves. We have the privilege to tell people how we suffer. And with that, I would really like to close this program. Unless I'm missing out on something, can the team members remind me if anything is missing?
There's a short poll, Kirtida, if you'd like to take it, just one small, or you'd like to skip it?
I'd like to skip it. It's okay. I think we've had enough.
For Dr. Kurian, I think it is amazing that he sat for 3 hours in this session.
Absolutely. I'm amazed at all of you with your busy schedule.
Which he comes, I can assure you, I mean, the total of the number of patients that we all have seen, he would have seen singly. During that time when there were hardly any doctors, so, and Vellore is a place where, it's both academics, and it is just amazing to see the kind of workmanship and the kind of devotion he has. I think we just need to learn. You can see that in Dr. Danda, no wonder. But Vellore is one place I feel all doctors should certainly visit to look at this, Thank you, sir.
Thank you.
Thank
I
you,
can see the people from Bangladesh also here in the group.
Yes, we have a lot of people from lots of countries. Bangladesh, thanks to you.
Indonesia.
Okay, very nice.
We have people from Indonesia, Bangladesh, Sharjah, Japan, and some other countries also. I don't remember all the names, but like you saw in the audience poll in the beginning, we had a large 90% of people who were from other countries. And this is only, let me just end by saying, this is only the beginning of the Sjogren's Dialogue. This was the very first event, and we will follow this up with more events and with more specialists coming in and telling us about the complexities of Sjogren's. We have dealt with only the basics today, but we will deal with the complexities. I mean, there are a lot of questions regarding neurology, gynecology, and so many other issues which we haven't taken up today, but we will have them taken up at the appropriate time. And whatever other questions we can answer, we will do so over individual responses or group chat. Or if we are able to arrange one more event where at least one of the doctors is present, we could have just a question answer session. But we will leave it at the moment because that will require for us to coordinate and find out whether that is possible. But with that, I'd like to close this session and thank you from the bottom of my heart, from all of you, to take so much time off. And it was wonderful to do this event. May we do many more. So thank you, all of you.
Thank you.
Goodbye.
Thank you. Goodbye.
And good night.
Bye.
Thank you. Thank you, everybody.
Thank you.
Thank you.
You can leave. Okay. Now, is the recording done? Can we close, or are we still doing the last bits? Okay.
I stopped the recording just now.
Right. Thank you, Neetu. Thank you, Neetu, for being here and supporting us. Pooja, I'm so sorry your internet conked up at the last minute. But
Neetu, can you stop the live streaming also?
Yes, that's what I'm just trying.